Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 229 of the Better Health Guy blogcast series. Today's guest is Dr. Clayton Bell, and the topic of the show is Supportive Oligonucleotide Therapy, or SOT. Dr. Clayton Bell is a leading integrative and functional medicine physician dedicated to helping patients achieve deep, lasting wellness. Dr. Bell works with Lyme and vector-borne infections, integrative cancer support, environmental medicine, including mold, mycotoxins, heavy metals, and detoxification, hormones, cardiometabolic and GI health, and mind-body balance. Combining his Western medical training with functional, integrative, environmental, and Ayurvedic approaches, he focuses on uncovering the root causes of health concerns. Patients benefit from personalized, whole-person treatment plans that empower the body's natural healing ability and support sustainable wellness from the inside out. Dr. Bell provides online consultations that offer accessible, holistic care tailored to each individual's needs. And now, my interview with Dr. Clayton Bell. I am very excited today to have Dr. Clayton Bell on the podcast to talk with us about supportive oligonucleotide therapy, also known as SOT, recently renamed to Q-Restrain. This is really a therapy for the last several years that I've kind of had questions about where it fits into the landscape of healing. And so as I had the opportunity to dig a little deeper for this conversation, I became more excited to learn about this as another potentially valuable tool in our toolbox. Thanks so much for being here, Dr. Bell.
I'm so happy to be here. Yeah, thank you for having me.
So tell us a little bit about your personal journey. What drives your passion for the work you do today? Was it a personal health experience that led you to becoming a more complex chronic illness doctor, or that led you to making SOT a focus of your clinical work?
Yeah, it's a great question. So kind of twofold for that. I think that the functional medicine landscape has always been more aligned with my philosophical and kind of medical value system per se. So I was always, even in medical school, looking for deeper, root cause analysis and deeper forms of healing, whatever those may be. And as far as getting into the SOT therapies or Q-Restrain, as you mentioned, they are now called by RDCC. Really, for me, honestly, it was getting Lyme disease myself, to be just totally honest about it. I had been highly functional. I was through medical school. I went through a fellowship in integrative medicine at the University of Kansas. I was working at an academic center, University of Tennessee Medical Center, and doing all the functional medicine consultations for the Cancer Institute as well. And so, I was performing at a very high level, but I had internal health things happening. I had a lot of adrenal hyperactivity, dysfunction, a lot of excess cortisol, had extremely low testosterone, in the 100s, lower than most 80-year-old men that I test. I also had right at borderline osteoporosis by the time I was 30. And I was a pretty savvy, well-accomplished mountain biker. So it's it doesn't make sense. I'm so athletic and I'm having these things. And then I had hypothyroid. I had lost 40 pounds one year during, I guess it was my first year of residency. And I thought it was from stress and just not getting enough sleep. And I had gone vegetarian that year. So I thought maybe I lost so much weight from that. So looking back, I was oh, wow, I got Lyme that year when I was in Maine. It made sense. And then it made sense why I had all that HPA access and the adrenal dysfunction, the low testosterone, and nothing I could do could really help that, no matter how much I meditated or ate clean or took care of myself, or it's there was still this internal challenge, stressor in my body, and I was just totally clueless that it was not only Borrelia burgdorferi Lyme, but when I ran the first vibrant tick panel on myself, it lit up like a Christmas tree. I had at least 6 different forms of Borrelia, and I had multiple forms of Bartonella and Babesia as well. And so when I actually started treating it, I did some antibiotics, I did some herbals, and then what really helped get me over the hump was the SOTs. And I remember I was somewhere probably about 8 months into my therapy, and things just finally started to click. I remember I put on 10 pounds of muscle, and then I put on another 10 pounds, and my thyroid regulated. I wasn't cold all the time anymore, and my testosterone auto-regulated without being on TRT or any hormone replacement therapy. and like my stress levels went down, and I just felt more like embodied and just healthier. And I didn't realize that I had been sick for a decade. I just, it was so slow and it was so continuous that I just thought that was normal. And then when I started to get healthy, I was like, oh my God, wow, I've been having a lot of brain fog and I haven't had as much energy and my mood has not been as good. And so it was really like getting healthier to that new plane of like awareness and consciousness and just vitality. And then it was like, wow, like I want to help other people too. And what I realized is I'm over in Western North Carolina in Asheville. But when I started testing people, I'm not saying that every single person has like an active flare or infection. But that being said, every single person I've ever tested, the exception of one or two people, and I've tested well over 300 people, they all have immune signatures of exposure to whether it's Lyme, Bartonella, Babesia, maybe Ehrlichia, Anaplasma, Rickettsia. So, and mold mycotoxins, which we'll get into too. But so what I found is these things are just totally ubiquitous in our environment. We all carry some of them around, some much more than others, and some of us are more sick than others at different times. And so really for me, it became a personal passion, because they say the best research is me search. And so I had to figure it out for myself. And then I figured out, we tested my wife, she has it. We tested my mom and dad, they have it. So it's like, wow, my daughter's unfortunately, she had a bullseye rash pop up because it was last summer, which is pretty scary. She's only 6. So it's like everybody in my family's had it, and I have hundreds of patients that I'm actively taking care of that have it. So I really just shifted my entire focus to really Lyme and then the mold by proxy, because so many patients with Lyme have mold. And then I do personalized cancer testing and therapies as well. But really that's 90+% of my practice now.
So definitely a pain to passion story and journey that you've had as well. As we mentioned, what we used to call SOT, and that's probably what I'm going to refer to it as in a lot of this conversation. They now call it Q-Restrain. That is the technology from RGCC in Cyprus, Greece. And much of their earlier work, they were really kind of known, I think, initially in the cancer realm. That's not going to be the focus of our conversation today. So we're going to talk more about the newer tools in the realm of Lyme and co-infections and viruses and things of that nature. So talk to us a little about why you saw a need for SOT in your toolbox, where it fits into the tools that you use for vector-borne illness patients. How long have you used SOT? About how many patients? And then talk a little bit about the clinical success. I've seen numbers put out there. Knowing myself, I've been in the Lyme co-infection mold realm now for more than 2 decades. When I hear really high success percentages, I kind of go, wonder if that's marketing or reality. So give us some landscape there.
Yeah, I'd be happy to. Yeah, multiple great questions there. So I'll just try to kind of answer it, break them down piece by piece. So as far as how does it fit into my treatment modality, when someone comes in, the first thing is diagnosis, right? Because you need the proper diagnosis so you know how to treat them. But let's say you get that, okay? And we're specifically talking about vector-borne illnesses here, so like Lyme, Bart, Babesia, and the other co-infections. And so let's say somebody has one of those, or usually, as you well know, it's usually several of those, right? It's very rarely ever just one. And so when people have those and they present with that, then we really kind of break it down and we can stratify it based on essentially what condition they have, what their desires are, what's in alignment with their belief system, and then also what's in alignment with resources, right? I mean, because I hate to say that, but it's just the truth of it. So for instance, let's say someone comes in and they're adamantly opposed to antibiotics. They've had a really bad experiences with the past antibiotics. They always have a lot of GI dysfunction thereafter, or they've had a lot of allergies to, to different various antibiotics. And they're just like, that's a no for me. Fair. Okay. Because if I give them antibiotics for, let's say, Bartonella, I'm going to be putting them on, Bactrim or Rifampin or, for a good 3 months, right? Same way with Babesia, they're going to be on like a Malarone and Zithro for like a 3-month period. And then with Lyme, if they just got it recently, that's awesome. And maybe we can give them like, a couple months of doxy and knock it out with some herbs. But, maybe they've had it for years, and that's really tough because you really need about 3 different types of antibiotics to cover all the different forms of Lyme, between the spirochete and then the cell wall deficient form and the cyst form. And so that's tough because I don't really want to put people on 3 antibiotics for multiple months. I'd prefer to do other things. But antibiotics are obviously an option, and they can be super effective. And I found them to be really effective and, life rejuvenating for a lot of people. Second realm, though, is like the herbals, right? So you have everything from like the Beaner protocol. There's lots of other programs out there now, and they're typically going to be sitting around a lot of the same herbs, right? Things like cryptolepsis, Japanese knotweed, skullcap, and there's a host of other ones as well. And those can be great. And I use those pretty much across the board with every patient, whether we're doing SOTs or antibiotics, just because there's so much additional support adjunctively as well. Sometimes that's all patients will do because they don't want antibiotics. and they can't afford the SOT. But I like to use them in combination with, I feel like it's a lot more effective to use the herbals in combination with the other treatments. SOTs. So if SOTs were free, I would give them to all my patients. There's no question about that. They're just, I mean, they're very, very safe. From a safety standpoint, really the only thing you have to worry about is Herx reactions. Now, this is specifically for the vector-borne infections and viral infections. Okay, in cancer, it's a little different. So I do cancer SOTs as well. And in cancer, we have some really specific contraindications, like if it's a larger tumor mass, like 5 centimeters cumulatively or more, or if it's in the brain or the lungs or the liver. I'm very cautious because the SOTs can kill the cancer, and while they do that, they can create some edema there, and so there can be kind of a mass effect, and you can get things like pulmonary edema or liver issues, or we definitely don't want any expansion in the brain, right? There's no room to grow there, and you can get tumor lysis syndrome. But so I don't even those patients that have really advanced cancers, it's not even on the table. It's not an option. It's clearly contraindicated from RGCC. Back to the Lyme though, and the viruses. They're very, very safe. What you might get though, what a lot of parents experience is a Herx reaction, very similar to what they're going to get with antibiotics or herbals for that matter, or sometimes biofilm busters. We give them biofilm busters and they're exposed now to all the bacteria floating around. So that's what you get. So with the SOT, it is very important. We'll get more into this later about how to mitigate, the Herx reactions to maximize success as well. But from just a purely safety perspective, I mean, they're very safe, and they're relatively speaking compared to what I've seen with herbals and antibiotics, they're very effective. Now they're not 100% effective. They're not a panacea. I tell patients they're not going to wipe out every spirochete Borrelia in your body. Like nothing's going to do that. My philosophy is that once we get Borrelia burgdorferi or Bartonella henselae or Babesia duncani, what have you, we're always going to have those organisms in our body forever, and that's okay. The goal is not to eradicate all of them. That would be like trying to eradicate every single speck of dust out of your home. You'll have to destroy the house in the process, right? That's not the goal. The goal is to knock down the pathogenic and the allostatic load that your immune system is stronger and can just keep things at bay. And you have it, but it's basically like a weed in the garden, and there's flowers everywhere, and there's an occasional weed, and it's not a big deal. So that's really as far as how I would use them. So like I said, if I could use them for every patient, I most certainly would. There is a couple of nuances to that, and I think we'll probably touch on this later. Like people with really advanced neurodegenerative conditions, I'm more cautious about, just because I feel like their advanced disease process doesn't lend to much resiliency with increased potential like die-off that might include some neural inflammation while it's killing the pathogens. And I've actually seen some of the neurodegenerative conditions temporarily get worse for a couple months before they round back and level out. And that's kind of scary. So I just don't give them to people that are that advanced. But by and large, 95% of your patients, I would totally give them SOTs for anything that's definitely an active infection. That's what just kind of context to, like how I use it personally. As an RGCC provider, I'm actually in a really blessed position to actually get the medicine from RGCC for myself and my immediate family members. And it's the company is extremely generous, and they just provide it for providers, which is amazing. Because I guess, the idea is that, well, if you do it yourself and you have felt the benefit of it in your own body, you're more likely to advocate it for your patients too. So it makes sense. But I've personally done 12 SOTs. I've given my wife 5. I actually have another SOT being made right now. I just came back positive for Borrelia mayoni. My wife just came back PCR positive for Borrelia mayoni and Borrelia Afzelii. I've had Afzelii, so we're probably swapping it back and forth sexually as well. Anyway, and then I've given SOTs to my mom every 6 months for her cancer, just to keep it from ever recurring, because she's done with her like allopathic cancer treatment. She's no evidence of disease, but she still has 10,000 circulating tumor cells, and we test her CTCs and give her an SOT to help just kind of mop those up to prevent recurrence, because we don't want to have to deal with all that again. So I use them for myself, and I would like to use them for more patients. It's just really just a resource game, just to be totally honest about why everybody doesn't get them.
So maybe touch on how many patients approximately you've used them with and what your success rate, your observations clinically have been.
That's a great question. I actually took a peek at this just the other day, kind of in preparation. And I know I started Medical in November of 2024. So we're 16 months in. And at that point in time, I had about 110 patients get SOTs in that, say 16 months. And then I was previously at Forum Health in Asheville, and I was there for about 4 years. And I've been using SOTs for about 4 years collectively. So I guess I was there maybe for 3.5 years. But anyway, in that period, I'd say we probably did at least another 200 there. So I've probably done 300 plus SOTs. A combination, probably, if I was just going to guess, I'd say maybe 100, 10, 20 for cancer, and then probably closer to 200, maybe more, honestly, mainly for Lyme, Bartonella, Babesia, but some for viral infections as well. Success rates. If you look at the only really, there's two papers published specifically on SOTs. There's a lot of papers on antisense technology. I mean, like thousands of papers on that. There's a lot of papers on like gene silencing therapies. There's multiple different, there's at least 10 different FDA approved drugs that utilize gene silencing therapy, the mechanisms of action. This is just the only clinical application that's used in like pathogens or cancer. But as far as specifically looking at Lyme and viral infections, there's one paper published. It's an internal paper. So obviously you have to, interpret it with that. As you well know, large studies cost millions and millions of dollars and are essentially only able to be done if pharmaceutical companies are paying for them, because they're the only people that really have that much money, unless you get a really specific, like NIH grant or what have you. So I'm not surprised there's not more. I know the lab's trying to like collect data, like especially the owner, Dr. Giannis, is really, really big on being data driven. So he's really trying to collect as much data as possible. There's a lot of confounding variables, as you very much know. So it makes it harder to like, it's not just like a stage 2A breast cancer, introductal carcinoma, you give this chemo and you assess, there's so many variables with Lyme. How many co-infections? They do antibiotics, not antibiotics, herbals, not herbals. Are they in mold? Do they even know they have mold in their house? There's 1,000 variables set, right? Anyway, that being said, just if I was going to pull all that information, like what's in my neurological system, as far as like numbers that come up for me, I would say that we probably get somewhere between, I would say around an 85% clinically success rate. And that's not an 85% improvement in symptoms. That's not like an MSQ or like a Horowitz MS-IDS score of like 100 dropping down to 15. But that's where like 85 out of 100 people, and some people get multiples, right? But within, sometimes it's a week or two, most likely it's going to be within 2-3 months, but they're saying, hey, like I noticed a significant difference with that SOT infusion. About 15% of the time, it's flat, and so why is it flat? Well, maybe we picked the wrong pathogen. Maybe the pathogen is an infection, but it's not having as many, active symptoms in their body, right? There's something else going on. Maybe we didn't diagnose the mold, which we pretty much test all Lyme patients for now. That's a huge one, right? Why SOTs don't work. Usually it's because they have mold or MCAS or SIRS, or something else, right? And so, I mean, and with those, as you know, too, if someone has like chronic inflammatory response syndrome, or MCAS, it's possible you could even clean out the bacteria. But if there's not a software update and a resetting of their neurological and immune system, their symptoms might not actually improve, even if the bacteria is not necessarily present. So there's probably a component of that as well. But I would say, have I ever had anyone get worse? I've had a few people with the like really advanced, like Parkinson's disease and ALS get worse for a few months. And then they all rounded back to baseline. I had a few people get better, but that deters me from giving it in those populations. But for the vast majority, like I said, in the rare occasions, maybe 10 or 15%, it's flat. And then, for say 85% of the people, there's a clinical benefit. Some is life changing. Like, oh my God, like my pain in my shoulders went away and I don't have headaches anymore. I don't have night sweats anymore. And like, I can function again, like I can work again. And those things. And then sometimes it's more subtle in nature. And it really depends too, like on how many pathogens they have, right? Like what are all the therapies they're doing, essentially kind of how primed they are for success. And a lot of what we do is not just the SOT. The SOT is amazing. It's a great therapy, but you have to do all the other things to make it effective. That's like checking for the mold, detoxification, supporting all the other pathways like methylation. Are they deficient in vitamin D, or, do they have a history of trauma that's never been fully addressed? Do they have autoimmune conditions as well? There's a lot to it. There's a lot. I think that's why you see the dramatic variance. If you look on like Facebook groups or you look on social media threads or people's blogs, that's why I feel like some people are like very strong, either advocates or detractors from the therapy. I think a lot of it is the nuances and the intangibles around the SOT. I feel like the SOT technology itself is sound, but there's a lot that goes into making it effective.
I already love the way you think about these complex chronic illnesses, this patient community, the fact that you're very holistic in your way of thinking. Let's just touch very briefly, since we mentioned, or you mentioned AOT or antisense oligonucleotide therapy. Is that more the underlying technology, the framework, and then SOT is kind of how it was brought out to the patient population? What is AOT and antisense?
Yeah, that's a great questions. Sometimes I'll actually even for people that are watching, it's actually not even a bad idea just literally to like pull up. There's some even like 2-minute cartoon videos on the way like transcription and translation works between like DNA and RNA and then creating proteins. And it's nice to get a visual of that. I know we're on a podcast, you can't see it, but I would encourage you to do that. And there's lots of, images that you can see about that too, and just make it simple. I mean, look for like someone that's a scientist that created it so that everybody can understand it easily. But for all intents and purposes, basically the way these antisense technologies work is they work as messenger RNA silencing therapies. So a good metaphor is everybody's familiar with COVID vaccines, right? With mRNA vaccines for COVID. The way those worked was they would actually insert a messenger RNA and it would create a spike protein. And then the spike protein was supposed to create an immunological response. I'm not going to get into all that, and that's a whole nother podcast times 20. But people are familiar with that mechanism of action. The way SOTs work is the exact opposite. Instead of introducing an mRNA to create a protein, you introduce a silencing mRNA to block a protein from being produced. So instead of creating a spike protein in the body, you actually prevent the spike protein from ever being created. And that's actually the way they work. But instead of doing COVID, they're geared towards very specific genus and species orientation. And by that, I mean, they're not. So, for instance, let's say you get a positive test from Hygienics or Fibrin or LabCorp or Quest for Borrelia burgdorferi, okay, whether it's an immunoblot or Western blot or PCR, what have you. So you send your blood, you get your blood drawn, you send it to the lab in Greece, right? And then they're actually going to isolate the organism via PCR, so polymerase chain reaction. And when they do that, they're actually using their Polyspot testing technology from their sister company, Biocentaur. And I know we'll come back to this later, Scott, but it seems practical right now to mention that. So when they actually isolate that organism, they're not just going to be like, okay, great. You have a positive test result, or we found, DNA that matches Borrelia burgdorferi. So here's the shelf. Let me get the Borrelia burgdorferi SOT off the shelf and send it to you. No, they're actually going to break it down and essentially sequence that genome. And, I was looking up today, and there's like 32 different plasmids that are genetic interchanges that basically Borrelia burgdorferi can use. So my Lyme's not the same as your Lyme, even if they're both Borrelia burgdorferi. And honestly, my Lyme today is not going to be the same as my Lyme in 2 years from now, or my wife's Lyme. It's all going to be changing based on this environment constantly with genetic expression. So they're actually like looking at it at the genetic level, at the DNA level, at the messenger RNA level, to create essentially a nucleotide sequence, which you mentioned is really the essence and the backbone of the antisense technology. So with that, if everybody thinks about it, you have like a double-stranded, double helix, two snakes cooling DNA. And then you basically have like an RNA polymerase that comes in and splits that. And then an RNA can attach to the DNA. And then basically the RNA will replicate itself. And so it'll look like the DNA. There'll just be a couple base changes on there. And then from that'll basically separate, and you have a messenger RNA, and the messenger RNA will attach the ribosomes. And that'll either be in the endoplasmic reticulum, or it'll be essentially like just floating around like in the cytoplasm of the cell. And then what it'll do is it'll basically start to make amino acids. And the amino acids are going to be like your building blocks, and those building blocks are going to make proteins, and proteins are actually going to create function in the body. So metabolism, reproduction, replication, so on and so forth. And essentially what the silencing mRNA is doing is going in there. It's trying to find that very specific sequence. So kind of like a glove on a hand, or like a jigsaw puzzle piece of that mRNA sequence. And it's just going to attach to it. So you can almost think about it like I use the reference like birth control. It's going to float around. It's going to attach to it. And it's basically just going to make it inept or unable to basically like reproduce itself or carry on its function. So it's going to essentially going to degrade that messenger RNA strand. And when you do that, it's almost like a knockout gene. You're knocking out function. And so it's very, very specific. And they actually test it. They actually test it like in silica. And then, to make sure, and then they'll test it like actually like in a dish too. It's not in the body, but it's, and then they'll send it back to you and put it in the body, and they'll change it actually. They'll actually reconfigure it if it's not effective. So they put a lot of time and energy on these, which is really, really interesting. And they test for it themselves. And one reason they do that is they say that so many people like don't know what they really have, if that makes sense. And then, they'll think they have one thing, but then when they test for it, the pathogen might be significantly more in a different species of the same genus or what have you differently. So it's very specific. And that's kind of the way it works. Another really easy way to think about it is like Pac-Man. So it's just like going around, and it's not like gobbling up. It's like a phagocyte, but it's gonna basically attach. And then when it does, it's gonna stick to it. It's not gonna attach to anything else in the body because you're not gonna have that, say, specific mRNA sequence. And so it'd be totally inert if you didn't have like that specific pathogen and that specific sequence. And so, yeah, it's very specific. It's not going to damage your cells at all. It's really just targeted towards the pathogen of choice. It's kind of like a Pac-Man birth control and just a really overly simplistic terminology. But it's silencing mRNA is the way it works.
So birth control for bugs, essentially.
Pretty much. Yeah, pretty much.
Before one can do SOT, they have to get a positive test for the specific organism at the genus and species level that there is an SOT available for. So let's talk a little about what testing RGCC will accept. If we think about things like IGeneX, Vibrant, DNA Connections, Armin Labs, iLabs, T Labs, maybe even LabCorp or Quest, are there certain ones they will accept, won't accept? Does it have to be a serum-based test versus a urine test potentially? And then if RGCC has to then find that organism again using PCR to then create the SOT, sounds like their testing is pretty advanced. So why do we use any of this testing? Why aren't we just using their testing?
Those are great questions. So testing, what will they take? They'll take blood tests, like blood serum tests. They won't take the urine test. They used to take like the urine tests, like the DNA connections. They used to be able to take that and you could look at the urine PCR, but they don't accept that anymore. I'm not privy to the exact reason why. From a practitioner standpoint, if I was going to hypothesize, I could only presume that they were getting positive test results and then not finding it in the blood of the patient, and then they were having to like basically do all that work and then refund the patient. Because if you have a positive test and you send it in and they can't find it, they send your money back. And so, they're out labor, and technology expenses for that. So that's my guess, but I don't know that. I do consulting for RGCC to basically educate other physicians and like advanced practitioners, but I don't work for the company directly. So I'm not privy to some of those decisions, obviously. But as far as blood tests, yes, if you get a positive blood test within 6 months of the blood draw date, then yes, you're eligible to get a SOT. So that can be as simple as a Quest or LabCorp Western blot. I've used those before when patients just literally could not afford to get, say, proper testing or better testing, right? But then also, so that counts, right? That's an antibody test. You can use direct or indirect test. So if you get a PCR positive, well, that's phenomenal. They shouldn't have any trouble finding that, right? But even if you get like an IgM positive test or an IgG positive test, now that can be like an overall, like immunoblot or like Western blot considered positive. But that can even be like, let's say you get a Vibrant panel. And on Vibrant, everybody's going to have some bands positive, right? Well, if you even if you just get one IgG moderately positive band, you can send it in and request an SOT to be made from that, and they'll search for it and see if they can find it. Now, obviously, the more, let's say, if your direct test, like your FISH analysis on IGeneX, for Barter Babesia is positive, or if your PCR is positive, and if you have multiple, IgM bands, or whether that's like IGeneX criteria or like CDC criteria, or even like multiple IgG bands, they're typically going to be able to find it. I've literally only had them not be able to find it 2 or 3 times. And then one of them was for me, and they just said, "Sorry, I see a positive result, but we can't find it. Like, here's your money back." And so to me, that actually created additional trust in the company, because it would be to their benefit to hand me something off the shelf, because I would never know, and they don't. They're like, "No, we can't find it. We did the work on it. Here's your money, refund your patient." And so I was like, okay, cool. So that's good. I trust things when it's not to someone's advantage and they do what would be considered the right thing. So that meant a lot to me, just from like a trust perspective, because this is very like kind of space age technology. You know what I mean? It's hard to wrap your brain around all the way it works. And so I wanted to, and that's the reason I went to the international conference the first time in Zurich, Switzerland, was I wanted to meet the people. I wanted to meet the lead scientist myself personally. And then really have that relationship where it's like, I know that person, I see where their heart's at. I see their intentions. It's not like a financial gain. It's like they're totally invested in this as their life work, And so that was a really important component for me if I was going to like recommend these therapies to people, because they're not inexpensive, as you know. And so that's the testing aspect. Now, a couple nuances to that too. When you order, you go into the RGCC portal under therapies, and then you would choose the specific genus and the specific species. So it's not just Lyme disease, right? It's Borrelia burgdorferi or Borrelia afzelii or, Mia moiti or Mayoni or what have you. Californiensis, right? Same way Bartonella, it's Bartonella henselae or Quintana, what have you. Same with Babesia, Duncani or Microti, what have you. And so now there is a nuance to that. let's say you get so I run a lot of IGeneX testing for patients that can either afford it or if they're Medicare, because Medicare covers IGeneX for free. So that is by far my favorite test for anyone 65 or older. I just ordered that TBD 6 IBL panel from them, which normally costs about $2,700, but it's a phenomenal panel. It's the best thing I've ever seen by far. And so anyway, if I get a Bartonella or a Babesia fish positive, oftentimes the immunoblot will be negative. Sometimes it'll be positive, or it'll be like Bartonella henselae indeterminate Bartonella fish positive. So if I get that, then I'm like, okay, great. It's probably the Bartonella henselae. And so let me order that one. But if just the Bart's positive on fish and the immunoblot's negative, in the same way, I actually kind of cross order between labs now to help patients save some money and try to get the best of both worlds. So the patient comes in, they're our age, they're under 65, they're paying cash. I'll actually typically order a Vibrant Tick 1.0 panel for them. And then I'll order the IGeneX Bartonella fish and Babesia panels if I feel like that is, a higher risk for them. Because a lot of times the Vibrant test, in my opinion, is great picking up antibody titers for all the different Borrelia species. But I feel like it misses or undersells sometimes the Bartonella and the Babesia. And there's a lot of times where I have a Bart Babesia negative test on Vibrant and I'll get a fish positive on IGeneX. And then, patients ask me, well, how does that happen? Well, those are usually kind of, I don't say worst case scenario, but more severe cases. It's like the body's ability to pick up the bug, the pathogen is so suppressed, they're not even making antibody titers to it. So it's basically just running amok in the system. And it's so prevalent that it's basically free floating around, and you can do a fluorescent in situ hybridization assay and catch it in the blood. So to me, those are that would be like the worst infection, right? Fish positive, antibodies negative. And then I'm looking for things. Well, here, let me finish that thought. So if you get a fish positive, but you don't know the speciation, you can actually order a Bartonella species or Babesia species to be done. And then they'll actually go in and they'll PCR it and they'll find it. They don't tell you like which species it wound up being, but I mean, ultimately it doesn't really matter. You're getting treated for it clinically. So that's an option. Yeah. So I run that. And then as far as the Vibrant testing, I think, a lot of times that PCR is going to be negative, and I've run 200, 300 panels on Vibrant, and I've seen less than 5 PCRs positive. So it's just a really low sensitivity. I always tell people, like, if it's positive, take it home, slam dunk, treat it. If it's negative, it means nothing. It's kind of like going to your PCP and getting an ELISA and a Western blot. If it's positive, great. You have Lyme. If it's negative, it's worthless. Doesn't mean anything. It's a really low sensitivity. So that's kind of the way that I use those tests. Now, you mentioned too, why don't we just go straight to the RGCC testing or their sister company, BioCentaur? Great question. I think it's a nuanced answer. Number one is, once again, it can be expensive. If you order the PolySpot test, that's going to be over $1,000 in and of itself. And if you order, and it's going to cover fewer pathogens than are going to be found on like a Vibrant panel, if that makes sense. And then if you order the Prime Spot test, which is by BioCentaur, which is going to be the viral infections too, that combination testing is probably going to cost you at least $2,500. So it could be cost inhibitive to people, especially if they're going to put that money towards the SOT. Now, I have some patients that I do order that, and that's what I order on myself. Actually, that's the test I just got back positive. So every 6 months or a year, that's the test I get on myself, because it's like, if it shows up PCR positive, I know it needs to be treated. If I get a Vibrant panel and I get 8 things back that have positive bands, I really have to be discerning about like what's actually really relevant, and what's more like kind of static immunological memory. And then, so you just have to interpret it all. And so basically, what they will do though is another nuance to it is when they're doing testing on their PolySpot or Prime Spot, doing the PCR analysis, they'll do this methodology and they go by spin cycles. And so the fewer the spin cycles, the more positive you had it. So basically means like they had to spin it down. Like you can almost think about, but you go like exponential, like 10 to the 10 to the 10 to the 10, right? So when they're spinning it down, if they find it at like 20 spins, that's a lot worse than if they found it at 25 spins or 30 spins or 35 spins. And so essentially what'll happen is they'll go to 35 spins. And the idea is that if we don't find it at that, yeah, it's maybe there, but like it's probably not clinically that relevant. So we're not going to go further. And so if you send it in, you might have like a really low grade Borrelia burgdorferi or Afzelii or Babesia microti or Bartonella henselae, what have you. And maybe it's like sub-threshold to their testing parameters. So it doesn't mean it's not there. It just means it's not enough. It's kind of like back when I was a teenager, right? Like, thinking about like a THC urine test, right? You had to have a threshold of THC in your urine to be positive. And even if you smoke marijuana the day or two before, it doesn't, the test could still be negative if you dilute your urine out and so on and so forth. So it could still be there in the system, right? It doesn't mean you don't have it. It just means it's not enough to meet threshold. So if you're highly suspicious that I have Bartonella, I know I got Bartonella, I know I got Babesia, or I have Lyme, maybe I want to get a Vibrant test so I can get a band that's positive, or even an IGeneX test potentially. But Vibrant's, I feel like the most sensitive, perhaps not as specific, right? So there might be more of an overshoot with Vibrant versus IGeneX, I feel like. And like I said, I use both those labs, like the labs very much. Love the reps at both companies. They're great. It's apples and oranges, right? They both have strengths. And so with that, it's like if I feel really determined that I want to get this SOT for this patient, and I'm kind of like I'm fishing for antibody titers to make the SOT, then I would go with the Vibrant because I can get a band positive, and when I send that positive test in, they'll spin it down to 40 cycles. And so even though it wouldn't meet their threshold on screening, they might find it if they spin harder, if that makes sense. And so it's kind of a game about like, what are the resources? What do you need? How aggressive do we want to be? How hard do we want to look for this and get the SOT done? So there's a lot of multi-tiered nuances to it, if that makes sense.
My observation with Vibrant is very similar, that they tend to find a lot that then you sometimes have to question which ones are clinically relevant, and that I generally see far fewer Bartonellas or Babesias than I do many other things. So it's interesting that you've had that same observation. If you do a LabCorp or Quest Western blot, I'm not sure if they have immunoblots now or not, but are we just assuming then that it's Borrelia burgdorferi and there's not the potential for some kind of mimicry or cross-reactivity between Borrelia organisms?
Yeah, I honestly don't ever order those tests. The only time I've ever ordered it is honestly when I had a patient whose Vibrant test was like past 6 months, and they basically just needed a band positive. So it was like, hey, like instead of spending $500-600 and get the Vibrant test, just spend $20 at LabCorp, go get your Western blot, get a positive, band, and we'll send it in for your test results. So that's really all. It's just not a good test. You know what I mean? And so it's just so low sensitivity, like less than 50%. And then I don't have confidence that it tests for any of the other, with Vibrant, at least we get 20 plus different species of Borrelia that we're testing for with the Western blot. I mean, my impression, I could be wrong, someone might come in and correct me, but I believe it's literally only for Borrelia burgdorferi. I don't think it's covering any of the bands. When you're testing with IGeneX, you're getting multiple different species. Vibrant's a lot of different species, and all these other labs too. I'm speaking more about the IGeneX and Vibrant because those are the two tests that I use. But I do have patients that come in with like Armin labs and occasionally T labs and things like that. And I'm sure those are wonderful laboratories as well. I just haven't personally used them as much, so I can't provide as much clinical expertise on those.
So let's talk a little bit more then about Biocentaur. You talked about the prime spot, which looks for viruses and Lyme-associated infections. There's 14 viruses, 16 cytokines and interleukins, and then one marker for Lyme. So that's not a deep Lyme and co-infection test. But then they do have their more detailed Lyme and co-infection testing, the PALDI spot, which looks to me like it has 19 Borrelias, 3 Bartonellas, and 2 Babesias. So I'm kind of curious that that's not really deep coverage for Bartonellas and Babesia. So if that's the test they're using to confirm the presence of a specific genus and species from a test that looks for more Bartonellas and Babesias, how are they confirming that with the PALDI spot, or is what they're using internally something broader than what they use commercially?
That's a great question, Scott. I would actually just have to ask. I'd have to refer that one over to Dr. Terry Baum or someone else on the clinical support team regarding that. So yeah, that's a great question. I'm really not exactly sure all of that because you're totally agree with you. I've ordered different pathogens that are not on specifically on the PALDI spots, and they're breaking it down. So I'm not sure. I would have to just honestly ask that question explicitly.
They don't even have Bartonella quintana on that test. So I was like, that's interesting. Yeah.
Yeah, that's a great question, actually. I would have to just defer that to the scientist and get back to you on that one.
One of the limitations from my perspective with SOT is this genus and species combination. So if you've got 4 different Bartonellas potentially, then you've got to do 4 different SOTs. You've got to get positive tests for all of those. We don't have the ability to do an SOT for all Bartonella. So I'm wondering, is it possible in the future that this technology could evolve to the point that you can do a genus level SOT, or that you could maybe do multiple organisms like Bartonella and Borrelia and Babesia? Is that a limitation of the technology, or is that it might just be too much for the body to process?
Good questions. I think both. I think one is that it is extremely specific, right? I mean, you're talking about nucleotide sequences 10 to 15 base pairs long. So you need to have basically combinations of nucleotide sequences or have multiple different nucleotide sequences from each, genus species orientation, and then pack it, basically, dehydrate it and then package it into a vial and then reconstitute it in, which would essentially be two or three SOTs in one. And that I would not do that. That would be contraindicated for me. When they send us those little nucleotide sequences, they're somewhere in the multi-hundred thousand range, somewhere between 500,000 and a million sequences. And so, if you had say 500,000 Billy Bardorferi and Bartonella henselae and say Babesia duncani, that load I think would be way too much on the system for the vast majority of people to handle. RGCC used to say you have to spread them out by a week, but some people got pretty aggressive and they were given like back to back to back several weeks in a row. And I think a few people had some adverse reactions, understandably so. Probably like Herx on top of Herx on top of Herx. And so now they say, hey, spread them out at least 3 weeks. In my clinical practice, if somebody gets multiple SOTs, I'd split them out by a month apart. If they're still in the woods, as far as having any Herx reactions, we slow it down. And so, you know what I mean? Like, they'll go, okay, you're still having some Herxing? No problem. Let's wait 2 more weeks. We can wait another month. They're shelf stable for 6 months. And so it's no rush to get them in the body. Most of my patients are getting 1, maybe 2, maybe 3 at a time. So, if something comes up, there's a vacation, there's travel, what have you, it's like, no problem. Just, we can do it next week or next month. So there's no rush on that.
So when you then send the sample to the lab and you're requesting a specific target organism, how are you as the practitioner determining which organism to create the SOT for? So if we think about Vibrant as an example, particularly if you, which I think most practitioners in the Lyme literate realm would consider IgGs relevant if there are symptoms to match. So we might see 10 or 12 of those on a tick-borne 2.0 panel. Would you prioritize IgM responses over IgG, even though we know with vector-borne infections, IgM and IgG doesn't really mean what it means with other infections? As you mentioned, you've seen 5 positive PCRs with Vibrant. I've seen 0. You've probably seen many more than I have, but they don't seem to be very sensitive with their direct testing. But if you do have a direct test that you've done, maybe from another lab, would you then prioritize direct test positives over antibodies like IgM or IgG? And does the intensity of the response on an indirect test also matter? So if you're looking at Vibrant and they kind of categorize yellows and reds and give you, numerical quantification, does that come into your thought process about where to start and where to go next? How do you create that roadmap for the patient when someone might need several SOTs over a period of time?
I love that question. That's great. And the answer to your question essentially is like yes, yes, and yes. So basically, if I get a direct test positive, that's going to be more preferential for me. So let's say I get a FISH positive or a PCR positive. Well, that's going to kind of be usually like, okay, obviously you need SOT for this one, right? Because some people might have 4 or 5 things that are positive and they can't get 4 or 5 SOTs. They have to pick 1 or 2 or 3, right? And so we have to pick, okay, we're not going to treat everything, but we'll treat the ones that are most important. And so if I get a FISH or PCR positive, that would be number 1. Number 2 would be essentially like the number of bands and then the magnitude of the bands and IgM, IgG. I just have to take all that into consideration. So if all things were equal, I would typically take IgM over IgG, even though so many people just have chronic, IgG infections. But if everything was equal, I would take IgM over IgG. And then after that, if it was the same number of bands, I would take, look at amplitude. Right? Like let's say Borrelia afzelii on Vibrant has an IgG or an IgM of 25, and then Borrelia californiensis has an IgG or IgM of 13. Well, I'm going to choose the afzelii over the californiensis, right? And then on the Vibrant test, sometimes with like Lyme, you have like a dozen plus different bands, so of course you're likely going to have 3 or 4 or 5 or 6, 7 bands light up. Afzelii, I think you get 3 or 4 bands. And then some of them, like Maritima and californiensis, you get like 1 band. And so if I have multiple different bands that are also positive, that's also leading me towards choosing that pathogen. Other things that will help me choose it is obviously like symptom clusters. We've got a high level step back view. It's symptoms, right? So even if I get a patient comes in, they're like, hey, I had this tick bite or what have you, and all of a sudden out of nowhere, I started getting panic attacks and shortness of breath, and I just can't catch my breath every time I walk up the steps. I'm getting night sweats now. Well, I'm going to get a Babesia SOT, even if they barely have anything positive, because it's obvious that that's Babesia. As well. So if I get a really clear constellation like that, I would choose that one. But most of the time it's smudgy. sometimes it's clear, but sometimes, most of the time it's like there's several infections going on and mold. And so it's hard to tease it all out with the history. Sometimes it is, but with those nuances, what I would do is, let's say there's 5 different Borrelia that have positive bands, and there's 2 Barts and 2 Babesias that have positive bands, and the patient's going to get 3 SOTs. Well, then what I'm going to do is I'm going to pick one from each genus. Because what happens, you mentioned earlier, you said, oh, well, do you have to do 4, say SOTs for Lyme or Bart? And like, you really don't, honestly. I mean, I very rarely will get two Bart SOTs at a time or 2 BC SOTs at a time. Sometimes Lyme. I've had a few patients recently who had a lot of Lyme infections. And they were clear on the other ones, and they actually got 3 SOTs for the different Borrelia species, and they had really, both of them had tremendous clinical responses. One gentleman had a complete Bell's palsy on the right side of his face, and it's like pretty much essentially resolved now, which is amazing. We also did ceftriaxone for him for 30 days and doxy for 2 months, but we did the 3 SOTs too, and he's just doing great now. Love it. But what I found is, let's say you have 2 Barts that pop up positive. If you treat the Bart that's what you think is most prevalent based on the lab testing, right? Then typically when you go back and look at the titers again, or the fish analysis, whatever, in 6 months, you'll see that both of them are improved. And I think what it is, it's really because you've reduced the immunological burden on the body, and then the immune system can start to attack the other ones. Kind of like Lyme. If you have 5 Lymes, and if I go after Borrelia burgdorferi, and that's the biggest one, well, your immune system can start to really work on the other 4, or EBV. So that's kind of the same thing. You definitely can do them for the viruses. And I have some patients that have had really good success doing things like HHV6 and, EBV, what have you. I do some for EBV, but honestly, I find that if I go after tick infections in the mold, typically the person's immune system can clear out the EBV. Whereas if I'm doing SOTs, it's almost kind of like doing continual symptom management to keep, you know what I mean? But it's like the EBV is just an opportunistic viral infection, and it's always going to be there. I need to work on the other things that are allowing it to continue in the body.
I wonder too, if you address one Bartonella with SOT, and you essentially now have these Bartonella dead body parts that are working their way out of the system, and there is some overlap between different species within the same genus. I wonder if that then wakes the immune system up to something that was a little more sequestered or hidden before. And so then it can start working on those, like you were saying, because the immune system is also going to be more able to respond at that point, less burdened. If we're thinking about someone with Borrelia, Bartonella, and Babesia, historically in the smudgy Lyme realm, we've heard practitioners treating the organism that they think is the most significant in driving symptoms for that person, commonly Bartonella. I've seen other people that will start unlayering things with the organism that they think is not as significant, like maybe Borrelia for a certain person. So do you tend to go after the kingpin first? Do you like to start unlayering those microbes that might lead to less Herxheimer response when they're doing a therapeutic intervention? Maybe SOT brings some regulation, vitality back to the system, and then go after their bigger issues? Or is the order always the same when it comes to Borrelia, Bartonella, and Babesia if they have a confirmed positive for all of those?
A really good question. I mean, I've talked to different providers that do a combination of all of those. I know some people that have very specific, like, Bart, Babesia, Lyme protocols. Myself personally, what I do is I typically go after the biggest infection first. Now, I try to prep the body on the front end. So like checking for mold, making sure that we've got that down. Because I found that even if you give the SOTs, if people have a lot of mold, they just don't really get better like you want them to and like they want to. And so you're more likely to need to repeat the SOTs or, continue other therapies. But a lot of the prep work that I'm thinking about, whether it's mitochondrial support and detoxification support and all those things, like I want to get started even before they do the first SOT. And then I honestly go after the first one. And I tell people, hey, like you might not know that you got this at all. And that's the way the cancer SOTs are. People are like, oh, I didn't know I got anything. It's like nobody ever does unless they have a really big cancer burden, relatively speaking. But with the Lyme ones, I tell people, hey, you might not feel anything, and that's great. And if you don't feel anything, then it's probably going to be a month, 2 months, 3 months later, you're going to just be noticing you're doing things you weren't doing before, or you're going to be in less pain, or whatever your symptoms are going to be lower. But I tell people, hey, like you might Herx on this, and I kind of prep them for that, and we've actually started using a lot of like Herxheimer support by Allergy Research Group. It's got a couple different bicarb salts in there. Nothing like what Alka-Seltzer Gold used to have, but it's also got like a little curcumin and boswellia. It's a very commonsensical formula, but I've been shocked how clinically helpful it's been for patients, not only with SOTs, but with like when we're doing like Malarone or, Definiquin or, other antibiotics. So that's been really helpful for people. And then we also do like, typically I'll get people, especially if they're sensitive, on things like liposomal glutathione or a binder as well. If they're prone to like histamine reactions or mast cell, then something like quercetin or just like straight up Zyrtec, another H1 blocker, things like that. Sometimes we have people like on ketotifen and cromolyn and some of the more advanced therapies. Yeah, those are kind of the big ones. And then being on good anti-inflammatories. If people are prone to like HSCRPs or SED rates, or they have a lot of inflammation in their body and joint pain, just making sure they're like on a good dose of like whether it's curcumin or like some of the resolvins or omegas or boswellia. And there's a whole host of anti-inflammatory herbals. But yeah, I honestly go after the big one first, and I'm like, hey, get a coffee enema kit on standby and like know how to use it. Because when I did my first SOT, I literally turned white as a ghost, just like hell that day, actually. And my partner and my wife, she's like, what's wrong with you? And I was like, what? I feel fine. But I literally had no color in my face. And I wasn't detoxifying very well. I had like a lot of like GI issues and some peristalsis issues, which I think could be related to all the tick infections too. Anyway, so I was literally constipated and I wasn't getting out all the toxins. So I started to get really toxic. And felt really bad. And then I started doing coffee enemas, and it like literally kind of saved my life. And I was doing them at one point like every other day or even every day for a few weeks. And then at a certain point, like I just kind of tapered it down, and now I'm not doing as needed. But I mean, I tell people, if you start to have like a major herxing, or if you're getting just like kind of toxic, that coffee enema is the cheapest, most effective thing that you can possibly do. It works like immediately. It's really incredible.
It's so funny how much overlap there is in our ways of thinking about this. So Tuesdays, Thursdays, and Saturdays are coffee enema days for me. And anyone listening, awesome. Anyone listening to this podcast knows that they literally, I think of them as life-saving interventions. That they have been Beautiful. Tremendous. Less so as I've become healthier, but back in the day when I had significant pain, they were really, really critical. I think that Herxheimer support product that you mentioned, if I'm not mistaken, I think that was created by Dr. Darren Ingalls. And that is probably a nice replacement, because we used to use Alka-Seltzer Gold, and it was a tremendous tool in this realm, but you can't get it anymore because they don't make it unless there's still some laying around somewhere. So that's a good tip with that Herxheimer support product that you mentioned from Allergy Research. You mentioned earlier that the gene sequence that's used to make the SOT to be that birth control for the bug is different for each person, even if it's the same genus and species, that's very personalized. Does every species of a given genus have a different SOT target region, or are there any scenarios where there's overlaps within the same genus, meaning that maybe the target for one specific Bartonella Henselae, for example, might also have an effect on another lesser common Bartonella at the same time?
That's a good question. And just to be totally transparent, I'm not exactly sure. I know like we talked about earlier with like some of the bacteria, like the Lyme especially, it has a lot of plasmid exchange that it can do, where things like Babesia, not so much. And apparently Bartonella can just like have horizontal like plasmid sharing with other Bartonella, which is really interesting. So they're literally sharing these genome structures back and forth. I guess it's possible, right? It's possible, but I just don't know that. I haven't done that bench research or been in the lab to be able to tell you that.
And is it possible that a Borrelia, Bartonella, or Babesia have mutated somewhat within a person? I generally don't know that they mutate that much within a single person, but I think maybe over time and many people, there are certainly mutations in these organisms. So is that where the fact that they're looking very specifically for that target site for that person would also be then addressing any potential mutations in that organism?
Correct. Yeah. And I think that's why it's more effective than if it was just like on the shelf, a stack of, Lyme or Borrelia burgdorferi, because it's literally like that person specific.
So in the Lyme, co-infection, and viral realm, talk to us a little about the SOTs that are available. I think I can put a link in the show notes that has the full list, because I know it's pretty extensive. But are there any missing in the Borrelia, Bartonella, Babesia, or viral realm that you think are clinically relevant, where you would be hoping for or advocating for new SOTs in the future?
I was actually just pulled it up this morning so I could look, and I was like, how many are there for Borrelia? And I think it's good. I know you put them in our show notes too, but yeah, I would encourage people to take a peek at those. But I want to say, I think it was like 18 or 19 for Borrelia. There's 6 for Bartonella, 6 for Babesia. And then I know you can get them for Anaplasma, Ehrlichia, and Rickettsia as well. And then there's a host for the different virus infections like HSV, 1 and 2, HHV6, EBV, CMV, varicella zoster, HIV, and then a host of other viral infections too. I mean, in a perfect world, I'd love to see if they had one for COVID. That'd be amazing.
That question is coming up.
Yeah, okay. I'll say I don't know if there's just so much variance, in the COVID, and it mutates so much that you can't keep up with it. I'm not really sure.
Or maybe it wasn't completely naturally occurring and thus has a unique way of replicating. Who knows?
I don't know. Yeah, it's just beyond. It's really interesting. So when COVID first came out, not to like derail too much, but I was at University of Tennessee Medical Center, and we were seeing some really serious cases, and I did some like IFM trainings about COVID and those kind of things. And then at a certain point, probably within about a year, I couldn't make heads or tails. I'm looking at two peer-reviewed journals, and they're telling me two exact opposite things, and it was so polarized. I was like, you know what? I got to focus on like cancer and other things that there's at least like I don't know. I can't figure out what the truth is on this. I have no idea. You know what I mean? It's like so. Yeah, the COVID is honestly just beyond me. It's a very complex issue. I know it's very politicized, but no doubt about it. A lot of people have suffered from whether it was COVID itself or vaccine injury. There's no question about that. So yeah, I wish they did have something for COVID. That'd be amazing. I know there was like more of a COVID preventative, like not a vaccine, but kind of a therapy that they had a few years ago. But I haven't really seen that, so I'm not really sure if that kind of fell by the wayside or what have you. Now I know that the scientists have been working on toxoplasmosis for a while now, and it's just I guess not quite ready for prime time. It hasn't been released yet, but I've had a few patients that pop up positive on their Vibrant Tick 2.0 panels, with toxo, and it's not available. There are other Borrelia species. From my understanding, I think there's at least 50 Borrelia species that cause either Lyme or tick-borne lasting fever, and there's not 50 SOTs. Once again, I don't think you really need to do an SOT for every single infection you have. You could, but I mean, I think that would be a little over the top. I think you really just need to continue to target the big ones and help bring the immune system into balance as well.
The other one that shows up almost always on Vibrant, and I don't know that they go down. Maybe they do go down to the species level, but strep comes up in almost every Vibrant panel that I've seen, right? So that would be an interesting one too, if they could get into coming up with some strep SOTs, particularly for the kids with PANS and PANDAS.
I was just thinking that when you said that, I was just thinking that.
Oh, it's a question coming up. Yeah, no, perfect. And I will try to link to this list in the show notes as well, but I'm sure some people will be interested. We've had a lot of debate the last few years about Babesia otocolii. Some labs, in fact, I think IGeneX has found it in ticks, if I remember correctly, but has never found it in a human sample. T Labs, on the other hand, finds it regularly in people. So it is interesting that there is a Babesia otocolii SOT available. So yeah, I think looks like they're definitely keeping up with the vector-borne infection realm. Let's talk a little more about kind of the foundational steps you might take for a patient before they do their first SOT administration. You talked about some of these, but would you already start the process of detoxification and drainage? Are you generally doing lifestyle things like stress, nutrition, sleep, getting them exercising? Does that even matter in the context of SOT? And then kind of building on that, do they need to be out of their moldy home first and address their mold illness first before getting into infection SOTs? What are the steps to set the stage for success with SOT?
That's great. Yeah, you and I think very, very similarly, very much alike. So answer your second question first. Yes, ideally. Ideally, I would always treat the mold or at least get it under control to a baseline before I would do the SOTs. And, like I said, we pretty much test every single patient with tick-borne infections. We give them screening questionnaires too, right? Like the MSIDS form and then like a mold questionnaire from like Dr. Jill Krista. And so, that gives us a better indicator of, hey, this person's probably also dealing with this as well. And there's a lot of overlap of symptoms, especially the strange neurological symptoms, between like Bartonella and mold. There's a lot of crossover there. So it's kind of hard to tease out. So yeah, if I can, for sure, I want to like get them under control with the mold first, and just they don't have to be totally eradicated because a lot of patients are colonized, and they might be on like itraconazole for 6 months, even after we have them on like say liposome glutathione and calcium D-glucarate and, binder herbal combinations, maybe prescription herbals, depending on the patient, so on and so forth. But yeah, so what I try to do is get that load down, right, where they're like less symptomatic from the mold and they're in a stable place, essentially. And then I think getting the SOTs on board, but completely concurrently with that, like in all my, like I do 1 hour, new patient consultations, and we're definitely talking about like, even on I literally have a treatment plan that breaks it down like bullet pointed. and I have it into different, basically subgroups. And it's, nutrition is the very first one. Then it's physical activity. Then it's stress resiliency. Then it's sleep. Then it's relationships. Then it's environment. And environment, we talk about, hey, if you have mold, then you need to get your house checked. And if your house is clean and you still have mold, when I retest you in 4 months, then like I'm going to treat you systemically, like it's living inside your sinus cavities, or your GI tract. And so, but that's a big thing. And I've had patients who literally just had an evaluation on their house. Sometimes their remediation's dramatic, and that's obviously very stressful, financially, and then you might leave their house temporarily. But so a lot of times it's fairly simple fixes, and people's health has radically improved when they've been able to identify, like water leaks and mold in their home, and then either get out of that home environment or get it fixed. And so, yeah, if you want this to be effective, you got to tackle the mold first, at least make sure, screen for it, make sure people are addressing that. And then at the same time too, if someone's, in a constant state of fight or flight, like they're just, a complex PTSD, still highly traumatized, that might not be the most appropriate time to introduce a medication that might induce herxing that we can't stop. You know what I mean? So, we might need to like help them find a safe place mentally, emotionally, spiritually, psychologically as well before they go into a really, because SOTs, I mean, they come in a little vial, but they are literally the most powerful therapy that I've ever experienced in my body, outside of so we'll say natural medicines, like such as some of the more like, kind of in the psychedelic realm per se. But as far as like, I'll say more like purely physiological therapies, SOT to me is the strongest medicine I've ever taken. And I try things that I give my patients too, because I don't want to give someone something that I'm not willing to do myself.
If we think about SOT working by blocking the replication of organisms, it seems then that we want them to be replicating. We don't want them to be threatened by an antibiotic or an antimicrobial herb. So talk to us a little bit about, do you have people stop their antimicrobials before testing as part of the SOT process itself? Does stopping the antimicrobials then lead to a higher probability that RGCC can find the organism in the sample to then create the SOT? And then once someone's had the SOT, should they stay off of antimicrobials for that entire 4 to 6 month duration where the SOT is working? What are some of the things that should be stopped? And then just taking that concept further, if you are doing SOT and you then are doing antimicrobials that could also be affecting and, let's say, killing organisms and leading to even more dead body parts in the system, is that potentially going to use up those Pac-Men on dead or dying organisms that can already not replicate and essentially waste your SOT?
Yes. All the same to the last. Yes, absolutely. And so that's one reason RGC actually has pretty explicit protocol. 2 weeks before the blood draw for the SOT, you want to be off all your, pathogen specific or viral specific, antivirals, antimicrobials, herbs, IV vitamin C, methylene blue, IV ozone insufflation, anything like that, right? So you want to be off of those. And that's so they can find it with their PCR analysis. That's pretty straightforward. And then also they want you to be off of all those same therapies for 2 weeks before the SOT and for at least 1 week after the SOT. To make it simple though, I just tell people 2 weeks before and 2 weeks after the SOT. And that also gives them a little more leeway so they can have some herxing and get over it. Because if we blast them with, methylene blue or cryptolepsis or doxy or whatever else immediately after the SOT too, it's like their body might just, it's like too much off. And so, yeah, I give people a 2 week window on both sides of the SOT, and then 2 weeks before the blood draw. And then I start if they're feeling well, right? Because also, Scott, you gotta temper it with, okay, you have X, Y, and Z, and I want to get rid of X, Y, and Z, but also like what can a person handle? And I find that especially with people that have mold, because they might have mold and they might want to get rid of it, but you might be at a quarter dose of the binder, and you can't even tolerate glutathione. So we might need to find something else that's more gentle on you. It's like if you pull out the mold too fast, people don't feel well; they get really sick. Same way with killing the bacteria or the protozoa. So we have to titrate it based on where they're at, while at the same time I want to try to be aggressive because I have a 6 month window per se. And so I want to really try to beat it while it's down. So I want to round back with herbals and methylene blue, because that's an antibiotic, has a lot of broad coverage. It does have coverage against, Borrelia, Bartonella, Babesia, the viral infections, clears COVID spike protein, helps to regenerate their mitochondria, complex 4. You can photosynthesize it with red light therapies. So that's like an antibiotic that I feel good about them being on for, say, 6 months. So a lot of times I'll do the SOT or sequence SOTs. And then when they're like back to running again, or, feeling well enough, I'll get them with, like, say, the cryptolepsis, Japanese knotweed combo, maybe some other herbs like a phytocidal mix, but with a molecular, or some other, like cryptolepsis synergy or something. And then I'll also get the methylene blue on board, treat them for 6 months and retest them after that.
So would you generally stop the antimicrobials for the specific target organism that you're working on? Or let's say you were working on SOT for Borrelia, Bartonella, and Babesia, but that person also has a history of chronic viral activation and is on acyclovir long term. Do you need to stop those antivirals or other things as well?
No, you can let it roll. You just let the antivirals roll. Anything that is giving them overall immune support, like their vitamin D or their vitamin C or, what have you, as long as it's not directly killing the Lyme, like low dose naltrexone. I have a lot of patients on LDN, and it's probably a good thing. I should probably have them all on LDN, for the most part, right? Just for immune regulation and T cell upregulation, so on and so forth. But they are totally cool to roll with LDN. They do not need to stop that before the blood draw or before or after the SOT. And if anything, it's kind of like them being on curcumin or, like the bicarb salts, we talked about with like Alka-Seltzer Gold. It's probably just going to make their experience a lot better, but it's not going to kill the pathogen. So it's not going to cause any interference there. Like you said, if you kill that pathogen, then you basically just have a bunch of like DNA or mRNA fragments floating around. And it's kind of like shooting a laser through a muddy puddle. You're going to get a lot of refraction. You're not going to get the best benefit out of that. So yes, I just wait on those. And then as far as like biofilm busters, because that's a big topic too, I typically don't do a biofilm buster immediately post SOT. And that's just to basically prevent an overload of pathogens in the system. I want to wait several weeks, maybe even a month or two. I want to get the other antimicrobials on board before we start to like blow open the biofilms as well.
So let's build on the LDN conversation and talk about immune modulation or creating immune tolerance to the microbe that you're doing the SOT for, so that when the body then sees that dead microbe and has to clear it out of the system, that it doesn't over-respond, trigger mast cell activation, trigger more inflammation. Could we potentially use something like low-dose immunotherapy from Ty Vincent's work before the SOT to create more immune tolerance and discernment to keep the immune system from potentially then overreacting and amplifying those Herxheimer reactions? So how do we minimize a negative response to the Lyme funerals that are happening throughout the body after SOT?
Yeah, that's a great question. I think LDI could be really great for that. I have a colleague, Dr. Andrew Peterson, who actually worked with me when I was at Form Health. And he has also been like a past president of ILADS, and he's done probably thousands of SOTs, but he uses a lot of LDI, and he's had a lot of good success with that. He would actually be a better person to ask how he dovetails it into the SOT therapies. I'm not trained in LDI, although I did, interestingly enough, when I was in my medical school, I really wanted to go to Alaska, to Anchorage, for my family medicine residency. And when I was up there, I happened to hang out and to be friends with Dr. Ty Vincent. I was actually spent some time with one of his good friends who was one of the people in the faculty up there. And I remember hanging out in a sauna with Ty one time. And
I was going to say it was probably at the gym.
yeah, we were at a ski resort. Yeah, but he was just such a cool guy, just so smart. And so it's funny because I think about him from time to time. I should really get trained in that therapy, but he was a genius. I mean, he's brilliant.
He's incredible. My own Lyme recovery journey has been significantly better because of his varicella zoster LDI. It made a tremendous difference. So let's talk then a little bit about the administration of the SOT. Is there anything the patient takes or does before the SOT is given to minimize potential reactions? Anything that's done to kind of keep that SOT in the bloodstream when you're administering it to maximize the effect? How long is the administration? Is it an IV drip? Is it a push? And then is this a relatively easy process for the patient to go through in terms of the delivery of the SOT into the body?
Very easy process. The whole process takes less than an hour. And that's with running like let's say a 250 cc bag after the SOT. So basically the process though is we have somebody come in, and it's like hop into the IV suite for an hour. We actually give them a gift certificate to go to the local breakfast place, Biscuit Head next door. So if they want to go grab some lunch, their family, they can do that. Make it a fun trip. So I tell people, hey, you're coming to Asheville. Make it a fun trip. Spend the night, bring your partner, bring your kids. It's like go hiking, go to the Biltmore, have fun here while you're here. People don't ever feel bad after the SOT. If anything, honestly, they feel better because one of the pre-meds is dexamethasone. It's not a high dose, like 4 milligrams. But a lot of people that are like chronically inflamed and adrenal fatigue syndrome, they get a little bump of that dexamethasone. They're the people that are like, I felt so good after my SOT. The next day I felt so great. And I'm like, yeah, that's the dexamethasone. That's not the SOT. But hey, no worries. If that, if you're feeling that good, that's awesome that you had that resonance point with it. So that's one med. So the dexamethasone essentially is just to keep the vein tight, because when you put the SOT in, you want to make sure it gets into systemic circulation and you don't lose anything. Nothing essentially like leaks out. And so that's what the dexamethasone's for, really. It's not even to prevent any kind of like allergic reaction or anything like that. It's really just keep the vein tight. The other medicine is basically we do like an IV famotidine. It's essentially like Pepcid. And you can take Pepcid orally like 6 hours before, or we just give it to people IV right before. It's easy. They don't have to worry about it. And that just prevents any kind of like histamine reactions. I've never had anybody have anything. Literally, I had one lady get nauseous, I think. And this is out of like 300 SOTs. She got a little nauseous and she got some crackers and had some water and she was fine. So like nobody ever has any reactions after the SOT. It's super simple. Like when my parents come in town, like we all go to the IV suite and get our blood drawn and get SOTs together. And my daughter hangs out and colors, it's just like, it's super laid back, super chill. It's fun because my daughter's 6 and my partner and I really want to introduce her to different forms of medicine. And so it's neat that she gets to see these things and she's already familiar with, oh, you're getting SOT and oh, you have Lyme. What is that? It's like, do I have Lyme? And I'm like, yeah, everybody has Lyme, honey, but that doesn't mean you're sick from it, so it's really interesting. It's new and it's cool to show her that people can get better because, as it's like you have a really personal story that's driven where you are right now. And so do I, but a lot of people are still in a really like, we'll say a dark place and they're still in the middle of their disease process. And it's really hard sometimes to see the other side of that. And so it's one thing that I love that really just turns me on and lights me up is that I get to see people get better every day. Now, not everybody's getting better every time, right? But it's like you're at least going to catch a couple people a day that have just had like life-changing recoveries, and that gives me a lot of like encouragement to help provide hope to the other people that are still going through the process. Because for most people with significant Lyme mold, it's a multi-month, maybe a several year process
or decade.
Or decade. Yeah. I have people that show up several decades in.
So a family that SOTs together stays together, it sounds like.
I guess so. I never thought about that. That's pretty funny. Yeah.
Let's talk a little more about these Herxheimer reactions after SOT. So maybe someone's having headaches or fatigue or flu-like feelings, kind of the normal Herxheimer reactions. Are you keeping people then on binders, on detox, on drainage, maybe things to alkalize the system while they're, weeks and few months after the SOT? And then I'd like to hear a little bit about what portion of your patients have no negative reaction, no Herxheimer reaction versus something mild, very tolerable, they're still functional versus a more significant reaction where they need to kind of slow their life down, pull back, take a little bit more care of themselves. And how long does that last? Are there any people where their Herxheimer reactions after many months or SOT after many months led them or left them in a place that was worse than their original baseline? And then one of the things building on that kind of made me wonder was if someone was having a really strong Herxheimer reaction, and this SOT is still kind of there, it seems like RGCC could make something that could then be injected into the body to bind all of that remaining SOT to kind of render it inert. But it sounds like we don't have that currently.
Not that I'm aware of. I have not heard that. Yeah, that kind of a blocker per se. Yeah, I think once it's in, it's in. So you want to be discerning on your patient population. There's some people that are just like super super fragile. Like let's say 80-pound 90-year-old woman. Yeah, I might not give it to her. You know what I mean? It's like just she might need it. She might do better, but I might just not take a chance. Because some people do get Herx reactions. Now, how do we prevent that? So the Herxheimer sport I found to be extremely beneficial. We already talked about like getting coffee enemas set up just in case things get intense. So I really like people to get their kit set up, train. And when I'm teaching people about coffee enemas, I'm like, hey, don't just make it one at a time. Like that's a pain in the butt, no pun intended. You don't want to be hanging out over the stovetop for 30 minutes, let it cool off. And then, it's like, make it and like, I'll make 5 or 6 at a time. And then it's almost like a cold brew concentrate, right? Then you just dilute it and heat it up to, body temperature when you want to actually use it. And so just so it's stockpiled and you don't, if you feel bad enough typically to do a coffee enema, you just want to make it as easy as possible. You know what I mean? To do it. And then when you feel better, you just do them for like prophylaxis, whatever, that's a different story. But Anyway, so, Herxheimer support is a great one. If you have any Alka-Seltzer Gold laying around, that's a great one. The coffee enemas backup. And then as far as things that people should probably all be on, either something like liposomal glutathione, which I found to be really helpful, whether it's the antioxidant support and the detoxification support, what have you. If price point's a big deal for people, you could put them on NAC, although NAC is a pretty potent biofilm buster. And so that's probably not the best thing to be doing right at the time of SOT. So I like glutathione. I also like a binder. Now, I don't have many patients on prescription binders. I honestly find that sometimes we have trouble with insurance, but practically speaking, it usually hurts people's stomachs. They get constipated and they don't like them. So I typically use some herbal combination. I use a lot of Quicksilver Ultra Binder, because I get that in a capsule form or powder form. And there's a sensitive formulation too for people that are really sensitive. They can titrate the dosing really easy based on the powder. I use MycoPool sometimes Z Binder. There's a lot of other good ones out there. Your charcoals, your clays, your fulvic humic acid, Shilajit would actually be a really good one. Any of those things are really beneficial. If people have, MCAS, then I think quercetin is really good. Get them a good quercetin. I use a lot of like Thorn, the quercetin phytosome, like 2 times a day. But whatever your favorite quercetin formulation is great. And that'll be a good mast cell stabilizer for people. And if you want to do something like Research Nutritionals has a histoquil, which is nice because you have some histamine blocking benefits, and then you have the mast cell because you like quercetin, you get black cumin, you get nettles, you get some other things in there. Besides that, that's kind of the big ones. Anti-inflammatory herbs, so like whatever your favorite combination of anti-inflammatories is. I use a lot of like curcumin, turmeric, but we use some resolvins. Some people have great success with resolvins, like the SPM actives and such. Some people are like omega, some people like boswellia. It's really just kind of user preference with those. People sometimes have to try different variations of herbs, and even like within the same class. Like one, they might really like Gaia, but they didn't like the other one as much, or they might like Thorn, or they might like pure encapsulations, or you got to try different ones. So those are kind of the main things that I do for people to keep them from having reactions. And then who has reactions? I like to think about it. It's kind of like a third, a third, a third. A third of the people will feel better like pretty immediately, not like within 6 hours, like post dexamethasone immediately, but I mean like within the next couple of days, they're like, wow, like I feel better. Oh my God, wow! Like it's just like you're like boom, and you're like, yes, thank you. It feels good, right? Because it's like slam dunk. They feel great. They're stoked about it. That happens, I'd say 25 to 33% of the time. About a third of the people, like I said, initially it's totally flat. And those are actually some of the harder patients because they're like, I just spent, X amount of dollars, on this SOT and I don't feel anything. Is it working in my body? And that's one reason I tell providers, like I coach SOT providers and everything too with RGCC, but I tell them, make sure you're using some kind of like objective, like data to like track their symptoms. Because I can't tell you how many people I've had that I see them 2 months later, 3 months later, and they're like, I feel about the same. Can't really tell a difference. And then I go back and I look at their medical symptom questionnaire. I look at their Hurwitz MSIDS questionnaire. I'm like, you're 34% better. You know what I mean? And they're like, oh, you know what? I forgot. I used to have that symptom. I used to have those headaches. I used to have that back pain. Oh yeah, my stomach hasn't hurt in 2 weeks. I forgot about that. People just forget that they were sick because they're no longer hurting. And so I think it's really important you track their symptoms. And I'm kind of a stickler for that. So I just, on my EMR, it just automatically sends them those basically forms every 2 days for every single appointment because I want to make sure it's working. And what's interesting, a lot of times I have people, they get an SOT, let's say for Borrelia burgdorferi, Bartonella, whatever, and we'll see 40, 50, 60, 70%, whatever, drop in their scores. Well, at around that 6 month mark, we'll see the score start to go up again sometimes. And it's interesting. I'm like, what did you do different? And they're like, I don't know. It's just almost like it wore off. And then we might give them a second dose and it'll drop again, but lower this time. And so it's not like it's one and done. It's kind of like everything you do, detoxification, meditation, physical activity, drainage support, SOTs, mold. You're all working together to bring the body into a new equilibrium and homeostasis. And then about a third of the people feel worse temporarily. And that can last for a couple of days, sometimes a week or two. I've had a few people recently had big reactions that lasted for almost a month. And now they're better now. And they're like, oh, I feel a lot better. But that month was tough. And I've only had a few people who got really severe that lasted for a couple months, but those are all like advanced neurodegenerative condition patients. And they did all round back to baseline, but I didn't like that feeling of them having worse Parkinson's symptoms for a couple months, so I just don't give them in advanced cases.
So one of the things in the Herxheimer realm with SOT that I heard was that one of the more significant ones can be Borrelia afzelii. So wondering if we know why that's the case. Could it be that the replication region for Borrelia afzelii overlaps with something else and we're really hitting several things beyond just Borrelia afzelii? Talk to us a little about that specific Borrelia and why you think some people may have strong Herxheimer reactions with Borrelia afzelii SOT.
Yeah, it's a good hypothesis. I'm not really sure, but I've noticed that clinically for sure. That's one of the nastier ones. It's a European strain, but I have people they're like, "Well, I've never been to Europe," or I have me and Moita, I've never been to Japan, so it doesn't matter. It's all cross contamination. People fly, you trade it around, it's everywhere. It doesn't matter. But anyway, yeah, it's kind of a nasty bug. It's hard to get rid of. I have honestly found if people have high titers of Borrelia afzelii, they do tend to hurt more with the SOTs of Borrelia afzelii. The first Borrelia afzelii I got, it hit me pretty hard. I like locked up my GI tract. Like I couldn't eat for like 2 or 3 days, had a lot of gas and bloating. And then after that, like my GI tract was better than it had been in years. Really weird. So I guess I just had some Borrelia infection in my intestines or GI tract, what have you. But that's it. I do see more herxing with that one. Sometimes with some of the Barts and the Babesias, sometimes with Borrelia burgdorferi, but Afzelii is one of the more prominent ones I do see more herxing with.
Is there a concept of pushing back one infection and then another infection becoming the dominant issue? So Wayne Anderson, Dr. Wayne Anderson, Dr. Eric Gordon, they talked about this years ago. So if you're doing, let's say, something for Bartonella like SOT, do you then see the symptom picture shift to maybe Babesia, where the immune system now is focused on the thing that you're not treating? Maybe there's also some real estate that you've cleared up in the body by addressing Bartonella, and now another infection moves in. We see that, I think, sometimes when we're dealing with fungal colonization from mold, and then suddenly there's a big yeast issue that kind of comes back in. So wondering if that applies to SOT, where maybe a flare after SOT is not related to the organism that you're targeting, but to something else then that's kind of become the more dominant infection or the focus of the immune system.
Yeah, and I feel like I've seen that clinically, and I'm familiar with that line of thinking too. When I first started getting trained on SOTs, it's because to do these, you had to get accredited by RGCC. You can't just do SOTs because you want to do them. You need to formally be trained and everything. But my teacher, who's a phenomenal naturopathic physician, Dr. Terry Baum, she really echoed this to me. And she's like, hey, just be aware if these people have viral infections too, you might treat, Borrelia burgdorferi and they might get an EBV flare afterwards or something else, right? That might pop up. And so, I have seen that. I feel like when we're kind of like approaching the person from a whole system constellation, we're able to manage that with people. But I think it definitely happens to some degree for sure. And that's why, like I said, if we could do SOTs for everybody, it would be great. If you get at least a BART, a Babesia, and a Borrelia, and then throw on the EBV, or if you have some other viral infections that are pertinent, that would be awesome, just so we can kind of temper the whole load down. But for all intents and purposes, I'd say yes. And sometimes it's hard to tease out what's a Herx reaction to that specific pathogen, and then what's like a different kind of a flare per se from a different co-infection. And there's probably honestly like overlap there. It's probably more of a blend than a binary, one or the other.
I've heard it said that SOT can last 4 to 6 months. Some will say that maybe there are a shorter duration in certain people. Do we know what factors lead SOT to work for a shorter or longer duration? Is it that scenario where other antimicrobials potentially lead to dead organisms that are then the SOT is then being used up essentially in that scenario? Is it related to maybe the quantitative amount of a given organism, where if they really have more, that the SOT is going to be used up faster? And are there scenarios where the body attempts to clear the SOT molecule as part of detoxification, even if it hasn't been used to block the replication of an organism? Can the body make an antibody to the SOT molecule itself?
Those are good questions. I would say yes to the first two. And I think that's why RGCC says, hey, don't give antimicrobials for, 2 weeks before and at least a week after, the SOT. Just because like we talked about earlier, you're going to, blow apart the organism. There'll be free floating DNA and messenger RNA, and you'll basically waste some of your SOT. It'll bind to that, and then can't use it for other active infections. And then the second one, if you have a huge load, yes, it makes sense to me. At some point, you're going to reach saturation with your SOT. Even if let's say you have 500,000 nucleotide gene silencing particles in there. If there's, I don't know, I'm just making up numbers. If there was like, 2 million bugs versus 200,000, you're going to super saturate at some point as far as you're run out. You're just going to run out of medicine basically. So I think that could be a variable as well. And then with the third one, I am not familiar with the body detoxifying these oligonucleotide sequences, and that's a great question. I know I read a couple years ago as I was like getting into this, and I'm like, what is this? Is this real? Like what is this stuff? And I like started looking at some of the basic science research on oligonucleotide therapy or antisense therapy is what a lot of it was called previously, and like these ASOs, these antisense oligonucleotides. So if someone wants to nerd out like I do, and I know you do sometimes, Scott, and you want to do a deep dive, if you want to look up research on SOT, you're not going to find much. You're going to find two articles, one with like Lyme and viruses and one on cancer. But if you want to do like antisense oligonucleotides, you're going to find a ton of articles on that. And then RGCC, I believe on their website, at least for providers, I know they even have like reference pages with a lot of different articles. A lot of them have been published by them, kind of bench to bedside research. But then there's like thousands of other articles out there. Like I said, there's at least 10 FDA approved drugs, using this technology. There's a couple of different ways to keep that oligonucleotide basically from getting metabolized in the body. And I read an article on it a couple of years ago. It's out there. Let's see what method they're using to stabilize the nucleotides. So they use it's called a phosphonethionate is the type of modification that they're making. And there's another ASO modification as well. Like I said, there's research papers if you just want to like totally nerd out on it. I understood the gist of it, but honestly, I'm a physician scientist, but I'm not like a bench side scientist. So some of the technology honestly was above my pay grade in that regard.
Are there any places in the body where SOT just cannot access? So can it pass the blood-brain barrier? Can it get to an organism in the skin? We think about maybe Bartonella or Borrelia. Can it get to organisms that are living within the inner tube of the gastrointestinal tract? What about areas that have lower blood perfusion and thus the SOT maybe isn't delivered there? Can it get to intracellular compartments where there's intracellular infections? Does it have any impact on persister cells? What about abscesses or localized infections or maybe vector-borne infections in dental cavities? And then you touched briefly on biofilms. Can SOT get to organisms that are sequestered in biofilms?
That is an awesome question. And I do not know the answer as far as how much it actually penetrates. I'm not sure if there have been any studies on that specifically with SOTs. I'd probably have to reference back to some more like the antisense oligonucleotide therapies and look. I'm sure that information is out there. I can say that clinically, what I have seen, I hypothesize that anywhere basically blood goes, those SOTs go. And I say that because in my own body, I felt it like in my GI tract after I got that really silly, SOT. I told you, I've seen a lot of patients have like neurological symptoms that either was a Herx temporarily or neuro symptoms significantly got better thereafter. So I don't know if that's because like it knocked down like the inflammatory cytokines that were crossing the blood-brain barrier and creating neuroinflammation, or if in fact it actually did cross the blood-brain barrier itself and started to clear out some of the, because, if you look at like McDonald's work, the pathologist out of Texas, when he was looking at patients with neurodegenerative conditions, every single one of them had spirochetes in their brain, right? And so, and syphilis gets into the brain, tertiary syphilis. So it's very common. And so I hypothesize it likely does penetrate there or potentially joint spaces, biofilms, abscesses. I don't 100% know, to be completely honest. I would be interested if someone has done research on that. It'd be great to see that. I don't even know how you would test that. Maybe you'd have to just do it outside the body, but it's a good question.
And what about biofilms? Like, where do you then find that there's benefit in bringing in the biofilm interventions to then maybe allow access for the SOT to get to the microbes that are sequestered within the biofilm?
If I was just going to give like a really broad, like simplistic answer to that, I would say I'd wait like a month after the SOT or until the person quit herxing. If they were having a longer herx, which is rare, most people are going to herx for like a week, 3 or 4 days, a week, 2 weeks. Very rare if someone herxes for a month. But I would wait till they're over that herx before I get the biofilm busters, just because we're going to reintroduce or introduce for the first time in a long time a lot of those bacteria into the system. And then we're likely to see more like inflammatory cytokines release, maybe histamine reactions, so on and so forth. But I would definitely not do it during the SOT. I would wait a good month thereafter.
So, building then on the biofilm conversation, many of us view hypercoagulation and the accumulation of fibrin as kind of the earlier part of a spectrum that eventually includes biofilms. We know that coagulopathies and clotting are certainly more common now in the era of COVID and spike protein. So, is it important to assess the patient's coagulation status and to optimize their blood flow for nutrient delivery, oxygen delivery, waste removal, but also then as a way to optimize the delivery of the SOT within the body? Could being on something like lumbrokinase or nattokinase for hypercoagulation before SOT set the stage for a better response, given the greater access then of the SOT to the organisms that maybe otherwise were hidden in biofilms?
Yeah, I think that's a great idea. I might actually have to start using that, Scott. I really like the way you're thinking about that. Like proactively on the front end versus like retroactively on the back end to open things up. But you're like setting the stage. So I actually really like that philosophy. I do use quite a bit of lumbrokinase. From my understanding, it's by far the strongest of the proteolytic enzymes, and so that'll help out with the fibrin, clot, so on and so forth as well. And the other thing is it'll bust open the biofilms and it'll open up, any kind of like microcapillary, circulation issues too. So that's all a big benefit for people. So yeah, I think actually prepping with that, but I would stop it at least, like I said, that 2 week window before, potentially I guess you could do it before the blood draw. It'd probably be good to do it before the blood draw, just to release organisms, they catch it. But yeah, I might slow down on it for a week or two before the actual SOT infusion, just so there's not so much of an overwhelming amount of the bacteria in the system per se. And the one thing that I think about that's like we don't often check for and catch, but if I'm having people that are having like hypoxia systemically and they're not getting good blood flow, and I think the people that jump out in my mind are obstructive sleep apnea, undiagnosed. I can't tell you how many people, and they're chronic fatigue, sure, maybe they have adrenal dysfunction or low B12 or thyroid, whatever. But it's like, oh, you're snoring, you're tired all the time. It's like, then you do like a stop bang questionnaire and they're like, 4 or 5 questions positive on that. And you're like, oh, look, I think you have sleep apnea. And it's like that, people ask me sometimes, oh, should I be doing HBOT? And I'm like, well, why don't you get your sleep apnea, assessed first and get on a CPAP? And then, HBOT could be like your icing on the cake, but you're not getting proper oxygenation. And as you know, like the Lymes, they thrive in a low oxygen environment too. So that's another like really key area that if you can get someone oxygenating well, then their body will heal a lot better.
The other one I wondered about is maybe doing pulsed electromagnetic field MAT type therapy to also
cool.
increase the microcirculation and help with the delivery of the SOT. Kind of on a similar idea, Dr. Dietrich Klinghardt, who's been a mentor of mine for many years, he had a strategy of using hyaluronic acid before antimicrobials to get Borrelia to come out of the tissues and into the blood where they were more accessible by the antimicrobial therapy. So wondering if using something like hyaluronic acid in the context of SOT to bring some of those organisms out of the tissues and into the bloodstream could also maximize the potential benefit of the SOT.
Yeah, it definitely could. I wasn't familiar with that mechanism of action, but Dr. Klinghardt's obviously, a mastermind in the field. So that makes total sense to me. That could definitely be a practical strategy to employ.
Are there organisms that you've observed that are one and done with SOT versus others that maybe are more persistent, maybe related to the length of their replication cycle, where it's harder to get real progress with one SOT, certain patterns where you needed to do multiple for a given genus species combination? And what's the maximum number of SOTs you've done for the same genus and species combination in a person?
So let me give you 2 extreme examples because it's a bell curve and most people are in the middle. So one end of the bell curve, as far as like a one and done, best case scenario, 8-year-old boy comes in, swollen knee, goes CD, gets Lyme checked. Turns out he has Lyme disease, right? He comes back and sees me like a year later, he's in another flare. And so given SOT, and then we're just, no symptoms anymore, totally asymptomatic. He's still got Lyme in the system, but we're just letting him rock out with like a cryptocomax, which is like basically, Japanese knotweed and cryptolepsis. And he's just on maintenance for that, right? No symptoms, one and done. Hopefully he'll never get a flare again. But, we're just kind of keeping some, good herbal support, kind of on board for that. And that's one extreme. The other extreme where like it hasn't worked. I've seen people that had like recurrent EBV flares or like, EBV early antigens stay positive and they got an EBV SOT. Didn't really make a huge difference. But at the time, like we didn't know they were like working in a moldy building either. And so, yeah, the SOT is trying to do its thing, but it's like, yeah, the immune system's still too suppressed. It's just not going to hold up. So that person would probably just continue to get EBV SOTs indefinitely and it would probably never knock it down just because the underlying factor that was really predisposing that was never fully addressed. And we didn't, that was a coworker in the past. I'm thinking of, we never fully checked all of her tick panel either. She wasn't my patient. She was a colleague. But anyway, so like those are kind of two extremes of ineffectuality and like super effective. Now, most people are in the middle. My mom, for instance, she's had a really sticky Babesia microti, and it's been PCR positive for a couple of years now. And I've given her, she's going to get her, I think, her second Babesia SOT coming up. But I've given her Aricota, like a 13-week run of that, pulse run of that. I've given her, she just finished up Malarone. I've had her on different combinations of artemisinin and cryptolepsis and she takes the artemisinin, the Artemis Plus by Natura Health is really effective on her circulating tumor cells as well. And so it's kind of a win-win. The artemisin's killing the Babesia and it's, knocking out the CTCs, which is great. But, last time I checked her was in December and she was still positive in her cells. And so, I've been treating that really aggressively. It's still there, and I've antimicrobials, herbs, SOTs, I'm doing it all and it's still there. But, she, for all we know, she could have had it for 20 years and that might've been one of the reasons she got cancer because she was immunosuppressed from the Babesia. We don't know, so that's kind of a different one. But for most people, it's going to be a spectrum. How many infections they have, how many co-infections, how severe is it, how long have they had it? Obviously, if they only have one infection and it's newly diagnosed, well, then the SOT is going to be way more effective than if they've had it for 30 years and they have 10 infections and you only treat one of them.
So I want to do some rapid fire through some conditions where SOT could potentially be helpful. So have you seen patients that were dealing with hypermobility or Ehlers-Danlos syndrome that had a notable improvement in their hypermobility when doing SOT for Bartonella or maybe another organism?
Good question. Most of my people with EDS are essentially like the hypermobility syndrome. They don't have the genetic package for the EDS. They haven't done SOTs yet. And that's really more just from a resource perspective. That'd be cool if they did. But the people that I have seen do better with that are the people that you clear the mold up. I feel like, they get the mold taken care of and maybe they have less like histamine. I've seen some research indicating that maybe that histamine hyperresponsiveness is leading to some of that laxity. So I have seen it with that. Same way. Now, what I have seen though is autoimmunity reverse back to negative. And so it's really common. I see people that come to me with, let's say, these autoimmune diseases, or even things like I've actually seen multiple sclerosis as well, or atypical multiple sclerosis, right? But then you diagnose them and they have like Lyme and mold and they have ANA positive, 1-to-40 ratio, 1-to-80, 1-to-160, whatever. But they don't have like straight up lupus. They don't have like Sjogren's syndrome or like mixed cell connective tissue disease, but their ANA is positive. Maybe no one's ever checked them or it's been positive for years. What I have found with them is if you give them an SOT or antibiotics or herbals, whatever, and you treat that infection, and if you get the mold cleaned out of them, I have seen their ANA reverse back and people be able to get off of biologic drugs as well. But a lot of it was just kind of, I don't want to say misdiagnosis, but it was a symptom cluster and they just got thrown on biologics, and then we tested what was likely causing it. And then we basically allowed the body to reverse itself. And then the ANA goes back to negative, which is super cool.
So in the mold illness realm, then we talk about the potential for fungal colonization. You mentioned the sinuses and the gut. We know that where there's mold, there's usually also candida, yeast. They tend to kind of come together. So is there a scenario where an SOT could be made to change the mold illness landscape and deal with fungal colonization and overgrowth of yeast?
Good question. I would say indirectly it's helping. So if it's kind of like if you lower the mold, it's automatically easier to treat the Lyme. If you lower the Lyme, which is also immunosuppressant, it's easier for the immune system to work on the mold, right? So I think indirectly, but as far as directly, to my knowledge, there's no candida, there's no like specific mold, or like mycotoxin, like SOT protocols out there. It would be those indirect benefits, not direct.
So when we're thinking about Lyme and co-infections, it seems that almost every person with Lyme also has mycoplasma. And it seems like many people with Lyme and many people without Lyme also have chlamydia. So do we anticipate that RGCC may be working on additional bacterial SOTs for mycoplasmas and chlamydias?
Good question. The one that I've heard about is the toxoplasma. I know that's been in the works for a while now. I imagine that they'll get that one finalized before they move on to other ones. I'm not sure what all's in the works. They're always brewing something up over there. They're pretty innovative. So the North American conference will be in November. And so those are fun because you get together with all the different practitioners and all the scientists and everything. So yeah, I'll actually ask them that in November so I can report back to you in the future on that.
Awesome. So we talked a little bit about PANS and PANDAS and the potential for strep. There is no SOT for that. I do see a lot of people, though, where Bartonella is the trigger for their PANS. And wondering, have you used SOT in any children with PANS? Is there an age limit for when you can use SOT in children?
Yeah, so when I was just actually, I was checking that this morning just to confirm I gave you the right age, but there's a contraindication, at least a strong recommendation not to use it in kids under 5, just according to the comprehensive guide for practitioners. So under that, no, but I'll be honest with you. Okay, that is potentially like cautionary in nature. Same way with like pregnancy, like it's contraindicated in pregnancy. But I mean, like honestly, like just biologically, hypothetically, it's probably if a woman's pregnant, she probably should get a SOT. I'm not saying I would not give it
To
because
stop
it's
congenital
untested.
transmission to the child,
Yeah, yeah,
right?
exactly. Yeah. So like if my wife got it and she was pregnant, would I give it to her? Probably. I would think about it. I would like talk to the scientist and get more information. But I mean, theoretically, it makes sense. Same way, like my daughter got Lyme, I guess it was about a year ago. And I actually tried to get her blood draw to get her an SOT because I know she has borrelia burgdorferi in her body. I saw the bullseye rash. I gave her Doxy, I gave her some Moxie. Her symptoms got better. Thank God she's not sick at all. But I know she's got it in her body. But I tried to get her blood draw and she was a little bitty arms, little bitty veins, couldn't get the draw. I didn't want to traumatize her. So it's like maybe this year, I'll try to get it again. But I would treat her with an SOT even if she's totally asymptomatic, because a lot of times with SOTs, I'm counseling a lot of people that are 50s, 60s, years old, and I'm like, hey, you're asymptomatic with Lyme right now. Like you think you came in for something else, you just have brain fog and fatigue, and then I run an IGeneX test on you. Then I found you have Lyme, Barton, Babesia, whatever. It's like, yes, I want to clean that infection out. And like for my parents too, I told them this 2 nights ago. So I want to make sure you don't get Alzheimer's. I want to make sure you don't get a neurodegenerative condition. So it's like, why don't we just do SOTs every 6 months or a year for you and then keep you from getting something that we can't reverse? Because once you get it, I don't know how to help you fix it and reverse it, but I can help you never get that. And so for me, when my daughter gets, when I can get the blood drawn or get the SOT and she can get the infusion, I'll just give her one for the rest of her life. Same way for me. I've got lots of Lyme and Barton, Babesia. I've got bitten by thousands of ticks. I've spent countless days in the woods, and I'm not going to stop doing that, but I'm going to take care of myself too, so that I don't ever get sick.
So I want to touch then a little bit on the viruses. So viruses, they don't really replicate on their own. They need our cellular machinery to multiply or replicate. So they're using our own cells to replicate. Some viruses are embedding themselves into our own DNA. So what happens to the cell or to the DNA when the virus that's within it has its replication region blocked by the SOT? Does the cell survive? Is that embedded virus then removed from the cell, or does the cell then have to die and be cleaned up through autophagy?
That's a great question, Scott. You should be a scientist, I feel like, for the lab. I don't honestly know that. If I was just going to venture a hypothesis, I would imagine if you silence the gene, it can't, undergo its either metabolic process, replication process, and it dies. I would assume maybe it would be similar to if you're, immune clearance via other methods that the body's already utilizing. I doubt if there's a unique specific method for that one. It's probably more like perhaps like an autophagy or a phagocytosis or what have you. But I don't know. I don't know that. I've never been privy to that information or seen that testing.
So in the era of long COVID, we know there is not yet an SOT for SARS-CoV-2, but we also know that long COVID in many people is an unmasking of their Epstein-Barr, of their Bartonella, of their mycoplasma, and things are no longer contained by the immune system. So have you seen people with long COVID where dealing with some of the organisms that were unmasked and then using SOT has helped resolve or improve their long COVID?
Indirectly, yes. Because we can't treat, right? But a lot of times, the things that I'm giving them for like their tick infections per se, whether it's like the LDN or the methylene blue, that's also giving them benefit for their long COVID too. And if they happen to have long COVID, but we happen to also catch a Bartonella infection or Lyme infection, we treat that. Well, of course, their long COVID's likely going to get better as well. So I have seen like that indirect benefit in those patients, even though I'm not specifically targeting the COVID per se.
You talked earlier about the resolution that you've seen of some people's autoimmune conditions by dealing with the microbe. Have you also seen shifts in people's either inflammatory markers or their mast cell activation?
Oh, yeah.
If you're looking at, let's say, labs for inflammation or even oxidative stress, what are some of the other things that you've seen improve that maybe you didn't necessarily expect?
Yeah, so like massive improvements in inflammatory markers. Like even during my initial workup, I'll get an HSCRP on everybody across the board. And it's very common that a lot of my patients have elevated numbers there. But yeah, when we treat the microbes, that tends to drop dramatically. They just have less inflammation in their body, less inflammatory cytokines floating around causing problems. Other ones that I've seen, I've seen the ANA flip back to negative, which is great. Another one that I wasn't really familiar with, I never thought about it, and it kind of just made the connection when I was testing people was ferritin levels. So it's extremely common for folks with these tick-borne infections as well as like the mold to have really low ferritin levels. And that's interesting. And I was kind of looking that up yesterday. The Borrelia doesn't so much like use iron as a fuel source; it uses manganese, which is really unique in the bacterial population, but Bartonella does. And then with Babesia, it lives in red blood cells, so it can hemolyze red blood cells as well. But I'll see low ferritin, especially in my old patients. When I'm seeing people with ferritins of 15 or sometimes even single digits or 20s, I'm like, oh, you got mold. Yeah, I'm gonna check you for mold. I know you got mold, and they always do,
Yeah.
essentially. And so what I have seen too is, yeah, I can give them like, so I don't give like iron per se if someone has a tick-borne infection, but what I'll use is lactoferrin. The lactoferrin can actually sequester the iron and actually be beneficial as well, and a lot of other immunological benefits. So I can give them lactoferrin, and it helps some. It gets it up a little bit, but really when we clean the mold out of the system, that's when I've seen the biggest benefit. Then and sometimes the tick infections, but that ferritin level shoots up quite a bit.
So, what have you seen clinically in terms of patterns with SOTs helping move the needle in patients? Is it more the Bartonella SOTs or maybe Borrelia or something else? Is it really individual based on the person? So, what are your top desert island SOTs? What are the ones that you really see making a difference?
Yeah, great question. So I would say it totally is individual orientation there. I have a lady the other day I saw, and she got a BCA. I think it was can't remember if it was Duncani or micro. I have to go back and look. Anyway, she got it back in the fall, and she's just like night and day different. And I have other people that have had that response to Bartonella and different ones with Lyme. So it really just depends on the person. I'd say whatever their biggest infection is, that's the one that's going to be the most effective for them, really. If I was on a desert island and I could only take one SOT with me forever, it would be, I'd say Borrelia burgdorferi. Because for me and for a lot of patients, it is kind of the kingpin, and yeah, even if you just treat that one, everything else tends to get better. Like I've literally done vibrant panels where I only gave them one SOT for Lyme, and then all the Babesia scores dropped, all the Bartonella scores dropped too. But it makes sense. It's like we opened up their immune system. Now, one caveat to that, I have actually seen people that were so immunosuppressed, they only had very small elevations in their scores on the bands, like low, moderate on the vibrant, and I gave them an SOT or two. And then the next time I tested them 6 months later, their score shot up dramatically. And that's also a good thing, because their immune system is actually able to pick it up now.
One of the things that I've heard Dr. Andrew Peterson talk about was his surprise at how some of the viral SOTs impacted systemic symptoms. So we think of HSV1, let's say, as just being lesions on the lips or cold sores, but we also know that it's been correlated to Alzheimer's. So what have you observed in terms of the benefit of some of the viral SOTs, and have you seen the effects be more systemic than you might have suspected?
I would actually defer more to Dr. Andrew Peterson. He's done a lot more of the viral ones than I have. I would say that 95% of the SVs that I've done have either been tick-borne or cancer, and like less than 5% have been viral. So I don't have the same breadth of patient experience with viral ones that somebody like Dr. Peterson has.
How long after doing an SOT would you retest to see if that infection has been addressed? And if you're retesting, would you use the same lab you used initially, or would it be better to use a direct test to look for the presence of that organism to see if, in fact, it has resolved?
Great. So typically I'll wait 6 months, like after the last SOT. So if I'm getting a series of 3 SOTs today, end of March, end of April, then I would wait till October to get the blood test. I typically will use the same blood test just so I get apples to apples. That being said, there's nuances to that. Let's say someone turns 65 and I can get a free Igenix test for Medicare versus they had to pay cash for Vibrant. Well, then obviously I think the Igenix testing is superior and it's free. So I'm going to transition to that. But for all intents and purposes, I'm going to use the same test they did last time. Unless let's say that they did maybe like a full Igenix panel, they had to pay out of pocket for it. The Bartonella fish came back positive, everything else was negative. Well, then I might subscale and be like, okay, we're just going to get a Bartonella panel for you. If you're totally asymptomatic, right? Because you got to meet people with where they're at.
Let's touch a little more on contraindications. So you mentioned pregnancy. I think breastfeeding is also a contraindication, recent blood transfusion. You mentioned the age in children as well. Are there any other contraindications or even incompatibilities? Like I've seen people in some of the SOT groups say, oh my goodness, like I took a steroid injection for something and I had done an SOT and I didn't think, and maybe that's going to cause a problem for the SOT. Or if someone's on IVIG, like to me, it seems like it's somewhat independent of the immune system, but are there other therapies that would be then not ideal to be doing besides antimicrobials if we're thinking about SOT compatibility?
Yeah, great question. One thing that you might have mentioned this, but it's like blood transfusions. So they really want you to wait like 120 days from blood transfusions as well. And then the other contraindications are things that I kind of talked about that are more on the cancer side, like size of the tumor mass, like location of the tumor. If it's in the brain, you don't do it, or like lungs and liver. But as far as contraindications go, they're fairly not too many of them. It's the pregnancy or breastfeeding. It's the recent blood transfusion, the age for the kid. Advanced neurodegenerative conditions for me is a relative contraindication as well. If I feel like a patient is just too tenuous, like just their health is just so fragile anyway, that might be a relative contraindication. Another one would be if a patient, this is more of a social issue, but if a patient is like just totally isolated and has a lot, because I'm all telemedicine. So like I see people in 7 different states, from Texas to Colorado to Florida to North Carolina, Tennessee, South Carolina, Georgia. Anyway, so if I have a patient who's living kind of on an island, they have no social support, they have trouble utilizing technology to communicate, like the patient portal, email. Most people could talk on the phone, but I might not give them an SOT, because if they get in a bad place and they can't reach out to me and they can't come see me, you know what I mean? Like it's maybe not the best fit. Maybe we should just try something else that's a little less, I don't know, aggressive or effective, you know what I mean? But it's going to be like, they can handle it if they have trouble at all, like a Herx. So that's social, but that's really about it. It's pretty clean, pretty easy therapy.
I think we've touched on this somewhat, but in patients that do multiple SOTs and are non-responders, how do you troubleshoot those SOT non-responders? What are the things or patterns that you see that are maybe preventing SOT from being a needle mover for that patient?
So what do we miss? So number one, what did I miss? I'm trying to, kind of own my responsibility of things. Like, did I check you for mold? Did I do the proper testing? Did I try to save you money and not do the right testing? And I am guilty of that. I lived in Haiti for 2 years. So I'm still transitioning from that scarcity mentality to one of abundance. And I have a lot of people that I'm probably overly paternalistic about them not using all their financial resources on testing and therapies. I probably hurt my patients more by not having them do spend the $2,000 to get the right test from Hygienics. It's going to save you a lot of money in the long run. Your return on investment is phenomenal. And then what'll happen is I'll get the Vibrant instead, because it's only say 550 or 6, but I missed the infection that's causing the problems. And I'm like, that's on me, right? Because I'm projecting, you know what I mean, where they should, and so it's I'm missing something, or there's something we're not aware of, like there's mold in the house, so on and so forth. Or the other big piece though, that even if you give them all the right therapies, are people that are just like, and we all have traumas, like little T traumas and big T traumas. But the people that are like in a perpetual state of like sympathetic charge and overdrive, sometimes no matter what I give those people, they're just in a place that they're not in a place conducive to healing. And so it probably doesn't matter what I give them or what I don't give them. Like there needs to be some type of like deep internal shift, like on a consciousness, soul, esoteric level, for them to be able to like move into a place of healing. And I've been there myself. I've been depressed before, so like I get it, But that's a thing. That's a real thing that holds people back.
Yeah, for sure. One more question before my wrap-up question, and that is, where in the world is SOT available? Is it United States only? What about other countries? Does it require FDA approval? And then what is the general cost people can expect to pay for SOT therapy?
It's available throughout the United States. You just have to find an RGCC provider. There is like an RGCC provider map that you can look at. Then you can pick, oh, I want an SOT, or I want cancer testing, what have you. And then you can look in your area. So it should be available in all 50 states. I'm sure there's providers in Alaska and Hawaii too. So that's a good reference for people. It is available in most European countries. Last year, there was some like political issues that happened with like some of the European Union and some of the countries. I can't remember if it was Poland or which country it was. Then they did temporarily withhold SOT from, and so the patients had to go to different countries to get them done. And I don't know if that's been fully resolved or not. I'm not sure. I think that was more of a political issue than a safety issue. But, like I said, I'm not privy to everything that happens in European sanctions and politics and such. And then as far as is it FDA approved? And the answer to that is no. It is covered by the European like medicines union, and it's basically considered an advanced biological molecular product there. And so it's individualized. So it cannot and will never be FDA approved. It's not like losartan or like simvastatin or propranolol. It's not like you have a condition, you take this med. It's personalized to you. So it just can't be. It really falls more in with like autologous products like stem cell or PRP as well. So with that, it's plus minus. It just bypasses the FDA entirely. So it's not regulatable. If that makes sense. But it is overseen, and RGCC is like a GMP, CLIA certified, all the credentialing, all the safety checks. And I can tell you what we do, and I can give you kind of a range. The least expensive that I have seen is about $2,000 per SOT. The more expensive that I've seen is somewhere around $3,500 per SOT. There's a wide range based on different models and what people's overheads are. We don't have brick and mortar, so I do all telemedicine in 7 states, and I have some advanced practitioners work with me, and then I basically have a nurse that I work with, and essentially kind of like pay her to do the infusions. So we have a really streamlined setup. I don't have near the overhead that most patients do. So when I tell you our price, I don't want you to think that anyone else is overcharging you. It's just that we have less overhead, so we can give a lot better deal to patients. But we charge $2,200, and that's probably underselling it, honestly, just because it's a lot of work on our end logistically. It takes a lot of time to prep patients and educate them and everything else too. So we're definitely kind of on the lower end of the spectrum as far as price goes. But I think you should expect it to cost, I'd say $2,500 would be a fair like that. And if it's 3,000 in your area, that's not necessarily wrong. It might just be the overhead cost of the provider in the clinic that you're seeing.
And that's not including testing. And then I'm assuming there are some appointments with you that are not part of that cost as well, correct?
Right. Yeah. So the appointments with me are independent of that. And then during the appointment, we choose whether SOT is appropriate for you or not. And then testing is not included. That's independent. You have to have the testing positive to send in. But, for us, that would include like blood draw and then infusion, and then paying RGCC, obviously, to get the SOT made.
My last question is the same for every guest, and that is, what are some of the key things you do on a daily basis besides coffee enemas in support of your own health?
Yeah, I think the biggest things for me are exercise and nature, because I'm so cerebral. Like I'm a Gemini. I'm like in the medicine all the time, always thinking. I'm always doing very complex problem solving, for like hours a day with patients. And so for me, it's just like turning my phone off and going on my mountain bike and getting in the woods, getting in the forest. So I try to do that, at least once a week. I try to work out every day. That keeps like depression at bay for me. If I don't move my body, I get pretty sick mentally. So just moving my body a lot is really helpful for me to just move that energy and keep it out of getting stuck in my cerebral cortex. And then I think also just like, the thing that I'd encourage everybody to do, providers especially, that we don't do enough of, is just self-care. And I'm not good at it either. It's a constant practice my partner and I are always working on. And then when you have kids, it's even harder sometimes because you always feel like you're responsible for everybody else. And that's one of the problems I see with my patients too, and fellow providers, is they're taking care of everybody else and not themselves. So like, why would their body heal?
I want to thank you for your time, your generosity, your knowledge, sharing all of your wisdom with us. I definitely love your approach, and you have a very clear passion for helping your patients. It's really helpful to know that there are practitioners like you out there to help those of us that have dealt with Lyme and co-infections and those that are still dealing with it. So very impressed by the conversation that we had with you. I hope more people will reach out, and just want to honor you for all that you're doing. So thank you, Dr. Bell.
Yeah, thank you so much, Scott. It was an honor being here. And if anyone wants to reach out and find us, we're at www.medical.life, and we'd love to help serve you. So enjoy, and thank you, Scott. It was obvious that you have a passion for this too, and I love that we have similar life stories. So thank you for what you're doing.
To learn more about today's guest, visit metamedical.life. That's metamedical.life. metamedical.life. Thanks so much for listening to today's episode. If you're enjoying the podcast, please leave a positive rating or review, as doing so will help the show reach a broader audience. To support the show, visit betterhealthguy.com/donate. To get my newsletter, visit betterhealthguy.com/newsletters. To follow me on Facebook, Instagram, X, or TikTok, you can find me there as Better Health Guy. This and other episodes can be found on Apple Podcasts, Spotify, Amazon Music, YouTube, and Odyssey.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.